live?
Yes, please.
Okay, just so it's 3, 2, 1. We are live to the audience. Over to you.
Good evening, all. Thanks to all the audience who have taken their time out of the busy schedule for today's evening. Thanks to Novo Nordisk for partnering with SPEED, that is Society for Promotion of Education in Endocrinology, for doing this growth update for today's evening. I'm extremely thankful to our faculty who have taken the time out of the busy schedule, and I think since many years they have been involved with the growth update. Thank you all the esteemed faculty. I think Dr. Deepak has worked hard on designing the scientific program for today's evening, along with advice by Professor Rajesh Khargawat sir, who has always been helpful in running these courses. I think it's very important to discuss how to approach growth disorders. It's very important for all the endocrinology students and pediatricians to have the right approach for patients of short stature. And I think we have one of the best faculties to cover the sessions for next 2.5 hours. It's my privilege to welcome Dr. Khargawat sir. He doesn't need any introduction. I think all the DM residents who have passed in past few years, and maybe more than that, they have learned the art of pediatric endocrinology from Dr. Rajesh Khargawat sir. He has a passion for approaching to endocrine disorders in children. He runs a dedicated endocrine clinic at All India Institute of Medical Science. And I still remember it goes till late evening. And when the sun has set, sir is still seeing the patients and guiding us. It's not from the books, but from the tips he has given to us over the years, how to approach endocrine disorders in children. So thank you, sir, for your guidance. We are always obliged to you. Over to Dr. Rajesh Khargawat, sir, for his words.
Thank you, Samir, and thanks to whole SPEED team for organizing this program on the growth disorder. It's really important, and like we are doing every year, we are doing this program this year virtually. So maybe by next year we may do by physical presence also. So this year's program we have total 5 sessions. First, we'll start with the lecture mode where we will describe how to decide whether it's a normal or abnormal growth and what are variants of the normal growths. And then we have a panel discussion where moderator is Dr. Sanjay Kalra, and we will discuss how to evaluate a case of short stature, including how important point to be noted in history and important examinations, and then how to investigate of short stature. So once we are through that, then we'll go for next session where we will learn the advances of the growth hormone treatment in case of childhood growth hormone deficiency. And one of the important discussions nowadays is, can we use growth hormone for non-growth hormone deficiency conditions? We get a lot of patients where parents request to give growth hormone for getting extra height in a normal child, and then there are certain indications where growth hormone deficiency is not there, and still we can use growth hormone. So in last panel discussion we will have discussion about use of growth hormone in non-growth hormone deficient conditions, and in the end we'll have all speakers and panelists together to answer if there are any questions. So it's important to know what's normal growth. So I hand over mic to Dr. Deepak to start with the program with the first lecture. Dr. Deepak.
Good evening, sir. Thank you very much, sir. And on behalf of SPEED team, I welcome each and everyone to all the esteemed faculty for today's evening. Sincere thanks. for everyone for taking time from their busy schedule. Thanks all the delegates who are listening to us right now. And thanks our partner Novo Nordisk as well as our logistic handling team Imagica. So without their help, the program is not possible. So I think as already told by Dr. Khirgawat sir, the first lecture is basically on normal growth. And I will just share the GB slides for the faculty. So for first session, we have 3 chairpersons. Dr. Dinesh Yadav, he is one of the leading endocrinologists in Behror, Rajasthan, MBBS from Maulana Azad Medical College, MD Medicine from Lady Hardy. He is also secretary for IMA Behror, a very learned person, clinicians, and a lot of interest in day-to-day clinical practice in the field of pediatrics. We have second chairperson, Dr. Nyay Bhai Gupta, who is senior consultant pediatrics, Sekhar Heart and Lung Institute in Lucknow. Again, he is a young dynamic person who has got esteemed interest for clinical practice as well as for academics in the field of pediatrics. We have Dr. Mukesh Verma, who is a very leading pediatrician working in Dwarka and Nazafgarh area. He is secretary for IAP Dwarka. He is senior consultant and unit head at Maharaja Agrawal Hospital in Dwarka, as well as senior pediatrician working at Ruchi Women and Child Clinic in Nazafgarh area. So I welcome all the chairpersons for this session. And I think for today's this talk, we have one of the best speaker that I know, Dr. Ashima Dabas. He is professor in Department of Pediatrics and also in charge for Pediatric Endocrine Clinic at Maulana Azad Medical College. She is graduate and postgraduates from MEMC, very learned person, lot of very high level of academics. And I remember, she had at least 25 gold medals during her graduations from Maulana Azad Medical College. She's a very active member in all the pediatric endocrine societies and a very dedicated person in terms of clinical practice as well as in research in the field of pediatric endocrinology. So I welcome all the chairpersons. I welcome Dr. Ashima for this talk. Our talk is summarizing normal growth.
Thank you, Dr. Deepak, and thank you, Speed, for organizing this wonderful update for all of us as a refresher and as a learning opportunity, and having a very good discussion. So without taking much time, I think I would like to begin my talk. I'll just share my screen. Right. So is my screen visible, and if I can proceed?
Yes, ma'am.
Okay, thank you. So over the next 15 minutes or so, my job is to basically talk about normal growth. So we will be talking about how growth is occurring, what are the patterns of normal growth, what are the determinants of this normal growth to occur, how is the relation of puberty very closely associated with growth, and I will towards the end not just talk about undergrowth or short stature, but also a problem of overnutrition that we see very commonly these days. So as we understand that growth is a continuous process. So for all life forms, it is a continuous process. It is personalized. So every creature would grow at their own pace, but a pattern would be similar. There would be different maturation of different parts occurring at different stages in the body. So likewise, if we were to see for a human growth, the appearance will change with time. The body proportions will be changing with time. There are different phases. So growth during infancy would be different from growth during childhood and during puberty. And obviously, even at adulthood, there is some growth occurring, not per se as linear growth, but a different form of aging or a senescence that we are talking about. The sequence, however, is very fixed. So even for any organism, or be it a human, when you're talking of human growth, sequence is almost fixed and would follow the normal sequence in normal maturing children. There are almost near normal timeline ranges that we know for a population, and maturation is what we talked about. So understanding normal growth becomes important, because as we will be going through the session over the next few sessions in the evening, we will see how a disturbance in this normal pattern or this normal sequence helps us identify growth disorders early and treat them. So what we would constitute as growth for childhood, for simple measurement patterns, these are external parameters commonly that we use and do as the anthropometry. I'll be talking about what parameters we usually measure and how we interpret. But the reason we are measuring these parameters is because we know that all parameters would be following a bell-shaped curve of the population, and there would be some who are under or some who are over on that scale. And these are the deviant patterns that we want to identify by our process of measurement and evaluation. The second important thing that we also measure is the pubertal maturation, especially in children who are peripubertal, to see whether this is in consonance with the linear growth or not, and if this can give us clue to any underlying pathology. However, there is growth happening at the levels of the bones, the internal organs. All of this might not be easy to measure. We do measure the skeletal growth in terms of the bone age, which again, I'm sure will be taken up in the case discussion as we proceed. So, as for any plant or any animal or any human for that matter, there are some factors that would be determining growth and would be deciding how a child or how that person is growing. So we know the role of genetics, the role of nutrition, some growth factors, which we'll talk about, medical problems and environment, which may adversely affect growth. So genetics, we know that tall parents would have tall children, and likewise. So parental influence is important. And a further deeper understanding of genetics now tells us that it is not just a familial or the genetic potential that we talk about, but there are a lot of genetic polymorphisms associated at the growth rate, which are actually determining whether this child is a familial short stature or not. Apart from that, there are some genetic disorders which will not be covered in my talk, but may be taken up later by our other experts, where growth adversely gets affected. Nutrition is very, very important to ensure that the child is growing normally, and the first 1,000 days of nutrition actually determines growth not just during adulthood and puberty, but also adulthood onset problems. So antenatal nutrition, we know the role of how maternal gestational diabetes would be affecting the growth outcomes of the babies. Low birth weight itself is a poor prognostic marker for metabolic syndrome and other problems in adulthood. Breastfeeding is protective from many, many disorders, and adequate breastfeeding ensures a normal growth, ensuring with supply of amino acids and other important micronutrients. Diet, both macro and micronutrients are important. So it is not just carbohydrate and protein, but also micronutrients like iron, zinc, selenium, which are all important for growth. Other medical problems, which are very, very common in childhood illnesses like chronic diseases, diarrhea, recurrent infections, these can adversely affect growth. Environment, we are talking of water, sanitation, hygiene practices, some socio-demographic factors like neglect, maternal education, smoking, alcohol abuse, where again growth would get affected. And finally, probably the focus of today's case towards the second part of the program would be focused more on how growth factors are important to be affecting growth. So as we understand, the hormonal influence of growth varies as the child grows. So during the fetal period, there are maternal factors and the role of fetal IGF-1 and insulin, which determines the growth of the fetus. As the child enters childhood, growth hormone and thyroxine are the major players that are determining growth. And towards puberty, in addition to these, the sex hormones are responsible for the pubertal height spurt and overall growth. So a word about IGF-1. So IGF-1, as we understand, is a protein and has a very strong impact, direct and indirect action on affecting growth. So the levels have seemed to be increasing steadily over the third trimester, and these would get affected by the maternal nutrition also. And likewise, the levels would be low in preterms and IUGR babies, and that may be responsible for growth-related disturbances that occurs in these children later. So this is the most potent molecule that would be stimulating cellular proliferation and has been shown to be responsible for fetal growth. So knowing that growth occurs is a continuous process, and there are various factors that would be affecting growth. So let us see how can we interpret, or how do we assure, or how do we measure growth. So there are two things to interpreting growth. We have to first measure, and then we have to interpret the parameters correctly. So the following parameters have to be measured at all children who present with any growth related problem. So weight, height, head circumference, body proportions, very frequently missed by most of us in a busy OPD, but they give us very, very important clues to case workup and diagnosis, and also of recent measures of obesity. So talking of waist circumference and waist hip ratios in these days where the pandemic has actually resulted in an increasing secular trend of obesity and overweight in children, it is not just undernutrition, but also overnutrition that we should be worried about during our well baby clinic visits. And then the interpretation. So something very basic from our undergraduation and post-graduation days, progression of weight should be known to a pediatrician as they are following up a child at their regular visits, or maybe for a visit for diarrhea, URI. We know birth weight for a 3 kg born weight, healthy weight, the weight would generally double by 5 months, would triple by 1 year of age, and would quadruple by 2 years of age, after which the weight would be steadily increasing at a fixed pace. Likewise for length, as per the birth length, for a 50 centimeter term baby who's born, by 12 months, they would be achieving 75 centimeters. Again, there is a pattern of increase of this length during infancy, which can be assessed at every monthly interval. By 2 years of age, they would be reaching around 88 to 90 centimeters. And by 4 years, a normal child would be around 100 centimeters. After that, there should be at least a 5 centimeter per year of growth happening in these children. And this becomes important because this gives us clues of monitoring the growth during a period and identifying at what point did the child started to falter. So if we can monitor and if we can record this height as the child is growing on a growth chart, it gives us a very, very beautiful pictorial description of what the underlying disease could be. Also, the pubertal growth spurt, where the patients are, where a child would be gaining their peak height, is important to be plotted. And this would be responsible for the major height gain that would be accounting for the near adult height. So some work on height velocity, as we understand that point-wise measurement of height may be difficult to interpret. So this was our work from AIMS under Dr. Rajesh Khatgawat, where we showed that for girls would be growing taller before boys. The growth overall would be shorter than that of boys, however, would also occur earlier. So in our population from Northern Indian school-going children, girls attained their peak height velocity during puberty, coinciding with their puberty at around 10 and a half years of age, and boys followed later around 12 and a half years of age. So similar work from Dr. Khadalgar's group from Pune, where they did similar work in school-going children, 5 to 17 years of age, and they also came out with growth centiles where we could plot the height velocity of both boys and girls. So any child who falters or is below this 25th centile of the height velocity is a red alert for us to investigate for a growth-related disorder. Right. The last anthropometry parameter, which very often gets missed even by a pediatrician, is the head circumference. The reason I'm talking about, and I spent 30 seconds, maybe 10 seconds on this slide, is sometimes head circumference is going to give us a lot of clues on the other disorders that the child has, and maybe giving us a composite measure of what happened. So when we talk of growth disorders, systemic disorders, it is not just physical growth, but we are also worried about their long-term neurodevelopmental outcomes. So monitoring head circumference becomes important here. Again, there is a set pattern, maximum growth occurring in the first 2 years of life. So monitoring children for their normal growth during that period is important. Right. Once we know what to measure, how to measure, which I presume my learned audience would be knowing that, we now come to interpretation. So the first and the most important thing that we need is a growth chart. Needless to say the importance of a growth chart, but just to reiterate that growth chart could be a growth reference chart where we have a reference population as were the CDC charts, or it could be a growth standard where we are comparing our population with an ideal or a standard data. So for Indian population, we use the WHO charts, which were formulated taking with representative sample population from 5 different countries across different continents of breastfed babies growing in the most ideal environment. And these charts were made. So this is a composite WHO chart, which can be used till 5 years of age, where the lower part gives us the weight centiles, the middle is for the head circumference, and this is for the length. So as we see during the first few years of life, the height velocity is quite fast, but towards as the child is around 4 or 5, it would slow down a little. And after 5 years of age, we use the IAP 2015 charts, where this part is the weight and this part is the height. As again can be seen, children would be growing steadily during the initial few years of childhood, but at puberty, they would be showing a peak. So these are the charts for boys, and likewise, there are similar charts for girls. So the use of the growth chart, I'm sure this will be taken up in the next session, but I just wanted to reiterate that whenever we are interpreting normal growth, we need to use a chart. So as of now, use the IAP chart, 2015 chart, which is the most validated measure of measure to interpret growth in Indian population. Then we would be always documenting the date of birth. Please do not presume a mother who tells the age of the child as 9 that he is a complete 9-year-old child. It could be 8.5, 9, 9.5, anywhere. So the interpretation could completely change with the date of birth. We are then worried about, we would then be plotting the weight and the height on this chart. So like, for example, I just plotted the weight for this child here and the height over here, and wanting to also check how are the parental, what is the parental height and how would that determine this child's growth potential. So a simple formula for mid-parental height, just a repetition. So for boys, it is adding both heights and adding 13 and then dividing by 2. And for girls, it is minus 13. This would give us the mid-parental height, and the target height range would be anywhere plus minus 6 centimeters. So a child could be growing anywhere around this to reach his adult height, which would be as per the genetic potential. However, in this graph, as we see, this child is actually short. He's short for the normal growth population, normal growth curve, and probably if we were to extrapolate this further, he's also short for his genetic potential. This also gives us at what age is approximately this child belonging to. So for this height, if I was to take back a perpendicular till 50th centile and then drop a parallel down, this child is somewhere at a height age of say between 6 and 6.5. However, the weight, if you can see from this chart, is not that poorly affected. So for a weight age, again, I take back this point, cut at the 50th centile and then drop it down. So this is around 7 years. So from this graph, I know that this child is not growing normally. However, whether this is a single point growth faltering or whether he was actually not growing well initially will only be possible if I had recorded his height and weight during his initial few visits that were made to a pediatrician or an endocrinologist. So to remember, please plot growth wherever possible at whatever opportunity you have with the patient. And I'll probably just end with this, that this graph also shows us that for this child, it is not the height and the weight which are affected equally. Height and weight did not mature equally, and it was height that lagged behind the weight. So again, clues for underlying problems or underlying pathological conditions that will be taken up in the next session. So these are the head circumference charts of the WHO, which are separate charts and can be used definitely by till 2 years of age, but should be used at least till 5 years of age for all children. So making our work a little more simple, we also have some apps which are freely downloadable, at least on Android, and can be used to document an objective measure of the growth velocity of the growth status. So this is the Anthrocal app, where we can enter the weight and the height, and that this would be giving us the WHO or the IAP Z scores, and likewise the IAP growth chart, which would give us a diagrammatic representation of the growth chart on our device, electronic device. So also helps in interpreting the growth centile of a chart of a child. So just a brief example of how growth chart helps us determine whether this child was growing normally or not. So showing you a pattern of aberrant growth where a 2-year-old child gets admitted with recurrent pneumonias, was born with a good birth weight, but at 2 years had started to show growth faltering. And if we can see the beauty of serial weight and height measurements, this is how the child had been growing, but somewhere around 1.5 to 2 years of age, he had started to falter. So whether this was only related to nutrition or whether it was repeated admissions or whether there are any other underlying systemic disorders is what, as an alert physician, we should be working this child up. So this is the definition of failure to thrive, not an uncommon problem seen in Indian children, very common, and has again connotations for long-term neurodevelopmental associations. The second part of growth, which should not be missed, is the interpretation of puberty. So as we know that at puberty, there is a GnRH pulse generator, which would be heralding the puberty. And there is a set pattern of puberty that could occur in both boys and girls. In girls, the first sign to occur is pylarchy, followed by puberty, then the growth spurt, followed by menarche, after which there is minimal growth, say about 5 to 6 centimeters. In boys, the first sign is gonadarche, which is increase in testicular volume to more or equal to 4 ml, after which there would be puberty and adrenarche. And as we saw in in the Indian data and the height velocity data, growth would peak later. So that is why most girls would appear taller to start with in any sample population for the same age. But ultimately, boys would peak later, but would end up being taller than girls. So as we have seen in our graphs, the textbook graph also shows a similar picture of height velocity, where during infancy growth is occurring very rapidly, then would slow down to around 5 centimeter per year during childhood, would have a little nadir in the pre-pubertal year, and then they would have their growth spurt. So earlier but shorter in girls, taller and more in boys. And this has to corroborate with the pubertal staging. So for stage 2 to 3 in girls, and then stage 3 beyond for boys. And if this pattern is not discernible in a child whom we are working up for short stature, please be very wary of more than simple causes of deviant growth. So I'll skip this graph for now because I'm sure this will be taken up later. But towards the last few slides, where I wanted to emphasize this time on the dual burden of nutrition, where we are seeing a lot of overweight and obesity these days. So the IAP chart that we have just seen, which shows the weight and the height, on the reverse side gives us the BMI charts. And these charts have been again collated from the data that we had. However, what has been made simple in these charts is the orange and the red line. So the orange line is any point, any BMI line above the orange would mean that this child is overweight for age. And any child who has a BMI above the red line would mean that this child is obese. So this is equivalent to the 23rd to the BMI 23 of 23 for an adult equivalent, and the red line over here would be an equivalent of 25 for an healthy adult. What has also been reproduced in a very recent publication, which came from the largest nutrition survey, the comprehensive 2016 to 18, are the waist. The cluster sampling was used to sample the population across all states of India. Children were sampled and were also measured. And through Metri data, they have reproduced these charts, which for the first time gives us waist circumference charts for Indian children. And we realize the importance of using these charts when we have to interpret children for metabolic syndrome and other problems. So these charts have shown good validity and reliability with the WHO and the earlier published waist circumference charts for Dr. Khadalkar's group. So just to summarize, as we reach towards the end, we realize that growth needs to be monitored and gives us very important clues. So how frequently or how can we do it? So till 2 years of age, we get ample opportunities during our immunization visits. And if we can plot simple height, weight, and head circumference at these three visits, it gives us important information for later on growth. Between 2 to 8 years of age, never miss an opportunity that the child has come to you for growth evaluation. Ideally should be done at 6 monthly intervals because these are the periods of rapid growth. And again, between 9 to 18 years of age, at least an annual growth assessment with pubertal assessment. And if there is any deviant behavior or if the growth velocity is not satisfactory, please call them frequently, at least 6 monthly interval for monitoring. So to conclude, we know that growth monitoring is an essential tool. We should know to measure correctly and then interpret growth parameters correctly so that we are able to identify normal and deviant growth early. Also, the use of growth and the interpretation of growth and puberty come hand in hand. And please use a growth chart which is appropriate for gender, use the right as per the age, and a race specific. So for us, it is the IAP chart. So with this, I think I can stop here, sir. Thank you.
Thank you, Asima. I think it was very wonderful presentation, and I think very quick summary about normal growth when we can see the growth is deviating. So I think it was a very, very important message and very, very helpful talk. So I think we have one question from Siliguri from Dr. Devarya. Practical approach to a child with short stature working in a periphery. So I think this will be
taken up in the second session. Yes.
So I think the questions are coming slowly. So I request you to stay here only, and if we need any help from you, we will get back to you.
Sure.
So the next part is panel discussion, and I think that is again very going to be very interesting discussion. Evaluating growth disorders, history, examination, and laboratory workup. So we have a moderator who is very well-known endocrinologist in India, and I think he really do not require any introduction. Dr. Sanjay Kalra. If I say Dr. Sanjay Kalra, I think that is more than enough for his introduction. He's endocrinologist working at Karnal, past president of Endocrine Society of India, vice president of CEPHIS, and more than that, he is a elder brother to all of us, very helpful to all of us, not only as a very big clinical practitioner, he has been a very big name in the field of academics as well as for research and publications. So I sincerely welcome Dr. Kalra sir, and we have panelist Dr. Rajiv Singla, very close friend of mine, endocrinologist working in Dwarka in Kalpaksh Healthcare. Again, a very academic person. He's doing a lot of work currently in the field of diabetes technology, carbohydrate counting, and maybe different kind of diets in diabetes remission. So I think a lot of interesting work that he's currently doing in the field of diabetes. We have Dr. Rahul Gupta, young dynamic person, joined as faculty in the Department of Endocrinology at AIIMS. He is DM Endocrinology from PGI Chandigarh. Welcome, Dr. Rahul. We have Dr. Mohan T. Sonoy, again, young dynamic person, endocrinologist working in Trivandrum. He is very active into field of academics, always there in every academic meeting. He's editorial board for thyroid research and practice, and very dynamic and very active person. Thank you, Dr. Mohan, for joining for today's meeting. And we have Dr. Jay Chodia, who is endocrinologist working in Udaipur in Paras Hospital, and as well as his own setup. And again, a young dynamic person and a lot of interest in academics. Welcome, Dr. Jay. So I hand over to Dr. Kalra for further discussion.
Thank you, Dr. Deepak, and a warm welcome to everybody who is logged in with us today. Also, warm welcome to our expert panelists, Dr. Rajiv, Dr. Rahul, Dr. Mohan, and Dr. Jay. It's a great being with everyone. And like Dr. Deepak said, endocrinology is actually a very small field, pediatric endocrinology. We all know each other, and it's this family atmosphere. And Dr. Rajiv Singla reminds me that the Navratras are going on. So the request is for no difficult questions from the audience, please. And if anybody has any bright idea, please feel free to share the solution to that idea as well. And also, we are reminded that tomorrow is a day which commemorates non-violence. With this, now I'm wondering whether my panelists are more relaxed or is it the opposite? But our work for the next 45 minutes is to talk about evaluation of growth disorders. Now, there is a hierarchy when you come into clinical medicine. First of all, you take a history, then you do an examination, and then you order rational investigations. So that is what we are going to do today. We'll talk about history first with all our panelists. Then we'll move on to examination, and then later on go to investigation. So we will follow that hierarchy. But our first question is there a growth disorder? If you've identified that there's a growth disorder, then maybe we would want to rule out nutritional causes first. If you've done that, then the next step in the hierarchy is maybe ruling out non-endocrine or maybe metabolic or medical causes, whatever word you want to use here. And the last would be to think of endocrine causes. And then even within endocrine causes, there is a particular hierarchy that we follow. It is good to follow this hierarchy or this systematic approach because that minimizes the risk of errors, both errors of omission and commission. And you just think of the theorems that you practiced while you were in school. So you were taught by your mathematics teachers to do each and every step of the theorem, not to skip out on any step. That is what we'll do today. So maybe Dr. Rajiv, just based upon history alone, how do we identify a growth disorder? Just history alone. Dr. Rajiv, or perhaps Dr. Rahul, you would like to chip in to begin?
I think, as rightly pointed out, if we see the epidemiology from epidemiological point of view, the various causes of short stretches, the endocrine causes constitutes even less than 1% of the overall causes. And as such, history, look for the other secondary causes is of utmost importance: malabsorptions, underfeeding, overfeeding, presence of chronic systemic illnesses. All these takes in important aspects that needs to be evaluated based on the history.
So in history, what is it that the child will come to you with? What complaint will the child have, or what complaint will the parents have?
So the parents primarily come with the apprehension of a short status, them being shorter than either the siblings or the fellow mates in the school. And in that background, the first thing we have to do by history is to have an idea as to the existence of any chronic systemic illnesses that may be related to presence of malabsorption symptoms like loose stools, altered bowel habits, altered urinary symptoms, or suggestion of some chronic cardiac illnesses like presence of shortness of breaths,
So
presence of cyanosis.
So the parents may come and say that we are worried the child is short, the child is shorter than siblings or cousins, or maybe the child himself or herself will complain that when I stand in school in the assembly, I am right at front of the class. There are only 2 girls who are ahead of me and all the boys are behind me.
Exactly.
That would be a history suggestive of short stature. Another history might be with regards to longitudinal changes. So Dr. Jay, Dr. Mohan, how would it work out? Maybe what will the child come and tell you, or the parents come and tell you about the uniform before COVID and the uniform after COVID, or the shoe size? What are the common things that you encounter in practice?
So from my perspective, basically, I would say that on a longitudinal scale, the parents complain now that the child was growing acceptably okay, and then suddenly we felt that he's not growing, and the younger sibling is growing more better as compared to the elder sibling. So this may be a one point which may show us an indication that definitely there is some issue. Pertaining to the shoe size, pertaining to the parameters, I don't think that in Indian scenario, parents anytime measure the height or weight of a child. Only when they go to a pediatric clinic or any clinic because of any reason, they just monitor the weight. So the anthropometric data is very lacking in Indian scenario. I think from the birth history till the puberty, if you want to calculate on the anthropometric basis what our theory tells us that what was the birth weight, whether the milestones were achieved, I don't think in clinical scenario any parent will come with a similar history or a good history of that category. So it is only the assumption which we can calculate via these points which you are telling, that whether the younger became more taller as compared to the elder one. In the school scenario, the height is on a lower side. These are the things which can catch up.
Dr. Mohan runs a pediatric clinic as well as an endocrine clinic. So Dr. Mohan, how common is it? My child's school uniform has not changed for the past 2 years. My child's shoe size has not changed. Is this common?
Yes, sir. Yes, sir. Because problem lies it because we had no school for the last 3 years or 2 years. So maybe that online was not at all checking that. But I think even in those times, the teachers used to have interactions, and but there was a very limitation regarding that. But after they have gone back to the school, what I have found out that the level of enthusiasm, like online education, was quite hardship for them because the parents had to sit with them, and it was basically both दोनों का कक्षा लग रही थी. Both of them have to study for that. But now what has happened is after they have joined, I think we run a clinic where we have got a Anganwadi worker also who comes in once in a while and checks. So a lot of community awareness is there in Kerala. So the growth charts are also integrated, and even immunization clinic, we have them readily available. So I think the availability of knowledge and the adequate staff is also quite important. So the shoe size and uniform size are well taken points, but the soft signs are very important. So I think I would just add to what Rahul has told: the onset, duration, and pattern of growth. Because in India, the children have got a separate, different type of pattern than the Western counterparts. So we should expect that what age their parents also had puberty is also important. So the tempo of their parents' puberty. So I think so many things put together, maybe we should also have a social environment and fabric to work on with. So that's what I find. We have to have a knowledge, 360 degrees knowledge, not just what meets the eye. Yeah.
So on history, the first thing is to suspect short stature. And you've added the concept, this angle of puberty. We'll talk about that. But Dr. Rajiv, let's say on history, we assume that the patient has short stature. We will come to examination later. Now we need to rule out various causes. So let's talk about nutritional and about non-endocrine causes. What kind of history would you want to ask your patients? We are mute, Dr. Rajiv.
Yeah, sorry. Good evening to all. So, sir, first of all, generally what I do at my clinic specifically is, even before we go into kind of detailed history, of course, we need to, as Ashima so elaborately pointed out, we tend to see as to whether child is actually short. And then once we know the height and weight of the child, then accordingly we tend to go with very, very specific and detailed history as to what can the possible cause is. So if we're trying to look at nutritional cause, so generally children with this category would be having their weight and height both on the lower side, which is telling us that there is a overall growth failure, both in gaining weight and both in gaining height. And then we need to look at what their nutritional history, as you said, is. So then we try to look at whether they have had continuous diarrhea or admissions for multiple admissions in the hospital. Then we tend to look at as to what their arm circumference is. And then we also kind of in nutritional history, because otherwise generally apart from your this diarrhea and vomiting and stomach aches, although worm infestation used to be very common in the past, nowadays in metro cities at least we generally don't see worm infestations per se. The most common reason generally that we as growth physicians try to look at is celiac disease, which of course on clinically you can have signs of associated other vitiligo conditions, autoimmune conditions like vitiligo and all. But generally the history would be similar to all other malabsorption syndromes that is there.
So that gives a fair idea of the wide spectrum of history that you ask for. First of all, as a practicing physician, pediatrician, you have to be aware of this. And like Dr. Rahul said, the endocrine causes will not be so frequent. It will be non-endocrine causes that you will encounter more frequently. So first of all, be aware of them. And secondly, know how to take a history as well. Dr. Rahul, let's continue with this. And we are still on history. We are on non-endocrine aspects of short stature. How would you take a nutritional history, and what is the concept of hidden hunger? How do we unhide this hidden hunger?
Sir, nutritional history again requires a lot of time and patience, especially if it has to be elicited. And the best person to take a nutritional history from is actually the mother of the child. And if that mother is not present at your clinic, you're more often than not you will have the wrong assessment of the nutrition. Again, as far as hidden hunger is concerned, again, the hidden hunger will depends upon the out of house calories that the child generally consumes in the form of the fast foods or the self-purchased food that he buys for himself, let's say in the canteens or in the shops.
So again, the point we are trying to make here is you should know how to take a good nutritional history. If you cannot do it, maybe your dietitian or some other paramedical staff can do it, but it has to be done. And when we are speaking of hidden hunger, of course, protein, energy, malnutrition, all of us are aware and we are able to figure it out quite easily. But hidden hunger classically has two domains. One is vitamin deficiency. The other one is mineral deficiency. Both of them can be associated with short stature. A vitamin like vitamin D or a mineral like calcium. But a third domain is electrolytes as well, though that may not be specific to short stature, but these three domains we should be aware of. Vitamins, minerals, and the third one is hydration and electrolyte status. These are hidden, but they are as much a part of malnutrition as other things are. So we've talked about history, Dr. Jay, and we've still not reached endocrinology. We are an endocrinology update today. Any pointers on history which will raise a red flag that yes, this person has a higher chance of having an endocrine disease? Just on history, we've not come to examination yet.
Yes, sir. So first and the foremost on the history part, when we talk about growth hormone deficiency or any form of dwarfism, family history. So whether the siblings or the mother, father was short, if that classical features what we see on a growth hormone deficiency, and Shaktivel recently showed also a picture of Larold dwarfism, classical pictures. So these are the facial pictures, very clear, chubby face, the growth hormone deficiency face, which can clearly give us an idea. So on my part, history, only when you talk about history, definitely the family history is important and the sibling history is important. That will give you an idea, sir.
So with this in mind, now let's go on to an examination, because that is how we are going to confirm our diagnosis of short stature. So Dr. Mohan, Dr. Rajiv, would either of you like to begin the discussion on anthropometry? How do we confirm a diagnosis of short stature? We are not talking about etiology yet, just the diagnosis.
Okay, sir. So the physical examination, there are a lot of clues involved. One is underweight. So we know that weight for age is also important. So we know the classical teaching is that the person grows as per the potential of that person. So there are so many factors for the weight. So if the person is underweight, that means that's a nutritional factor, infection factor. Small for gestational babies also grow shorter than what they require. They are actually shorter for that potential. We will make it up later on. Then there is also what Rahul added, it is malabsorption, because we don't have celiac diseases in our part, but still that is one of the causes which we keep in mind for underweight children. Then the overweight, that's very much nowadays we are seeing very non-hormonal causes are also there. But these are some hypothyroid, then Cushing syndrome, then growth hormone deficiency, as we know, may have the overweight chubby fishes, then IGF deficiency, as you have told. Then comes pallor, that nutritional deficiency has, but one condition which is important is thalassemia, because thalassemia has got a potential for endocrinopathy, so that's also important for a pallor. Then we also know frontal bossing and mid-facial hypoplasia. These are the classical features of the growth hormone deficiency or resistance. I would just like to finish by also mentioning that there is also some conditions where you have macrocephaly. So macrocephaly means the head is also larger than what we actually expect. For that, we need to measure with the head circumference, with a tape, occipitofrontal circumference, we call that. So that is maybe seen in conditions like birth asphyxia, then symmetric SGA, that is a symmetric short stature with a growth hormone deficiency that's having. Then on condition can be there with cerebral gigantism or Soto syndrome. So these are the simple conditions which we know. Of course, genetic conditions have got a classic appearance like Russell-Silver syndrome, like a Seckel syndrome, bird-headed dwarfism. So many things we know by interacting with the geneticist.
Dr. Rajiv, would you like to take this forward? We've done a height charting, we've done a weight charting. We've seen the percentile of the patient. In which situations can we say that with just a single set of values, we can label the patient as having short stature? And in which situations would you want to do a longitudinal follow-up before labeling the child as having short stature? To unmute, Rajiv. Unmute.
Sorry.
That is like hidden wisdom, like hidden hunger.
No, so yeah, so sorry for that. So I was saying that before I go on to kind of tell that, because I think there was one question in the previous session as to how do we look at the diagnosis of short stature in periphery. So I think it's very important for us to know that for taking this discussion forward, we need to know how to measure height, first of all, this thing. So normally speaking, we need to have a good stadiometer, a wall mount stadiometer, which hardly costs kind of 200 rupees and can be taken at Amazon. Then you need to mount it on the wall. Then you need to measure the height in a proper way with your heels, buttocks, and back of the head touching the wall with your line. If you draw it from top of your pinna to your angle of eye in a horizontal line. So because these smaller the children, even the smaller changes in the height measurement can change their percentile very, very visibly. So you measure that height and then we draw it on a growth chart. And then we draw their weight on the growth chart. And then the relative information between your height and weight tells you a great extent as to what history to be asked, what all points need to be kind of emphasized on examination, and then further investigations. Now, once we've done that, if we are just trying to look at whether the child is short or not, so we need to look at two basic things. We need to look at their growth vis-a-vis the population, which generally the chart would give us. And then we also need to look at their growth vis-a-vis what their mean parental height or their target height is going to be. So as Ashima has already discussed, that the mean parental height would be for boys would be mother's height plus father's height plus 13 divided by 2, and in girls case minus 13 divided by 2. So then we have to look at from that percentile. So say if your parents' percentile is at fifth centile, if the target height is already at fifth centile, then even if child is slightly below fifth centile, then it would be difficult for us to classify or to find any biological causes for that short stature. Then we would have to look at that it's a familial short stature. Whether to treat it or not is a different question. We're not going to go there. So, but that's what we look at. So if you are 2 standard deviation lower than mean parental height is something that I would label somebody as short stature. If child is already less than fifth centile for the population charts, then also we need to consider the child as a short stature, and then a evaluation should be done for further causes for that short stature.
So the first thing we did was chronological age, because without that you can't fill the height chart and the weight chart. So CA.
Right.
Then what our panelists are telling us is you do a height charting and a weight charting. That will give you the percentile. It will also give you the height age and the weight age. So now we have 3 things: chronological age, height age, and weight age. The next investigation, Dr. Rahul or Dr. Jay, what other age do we add to this so that we can get a fair idea of the differential diagnosis?
So after having an estimation of chronological age, height age, and weight age, the next step should be to have an estimation of bone age. For the same, one requires a properly done X-ray of the left hand plus wrist with an adequate exposure where from the tips of the finger till the proximal distal 1/3 of the radius is clearly visible. And this X-ray can be compared with the available reference standards. Commonly, the common one used are those by Grulich and Pyle, a Tanner Whitehouse 3 that is available.
I'm old school, so I have used TW2 when I was a fellow, and then I graduated to TW3 when it came out. But now I see that the younger endocrinologists are more comfortable with Grulich Pyle. My radiologist who helps me out, he is very comfortable with Grulich Pyle. So, Dr. Jay, what method do you use in Rajasthan, and what does it depend upon?
Because when I was doing my DM, sir, my guide asked me to purchase a book of Grulich Pyle. Basically, that was the time when you used to read and then you used to see and match the similar things. But at this point of time, when you all are so busy endocrinologists, I don't think that we personally exactly calculate. Definitely now we have softwares also. TW3 may be available in applications. There are good applications available, so you can calculate it via just figuring the picture also. That radiologist is a good person to tell us, but we have to be more precise, like what you are talking about. You have to ask the radiologist that this should be a perfect relation, this should be a perfect report, because any deviation from that will give you a segregation on your diagnosis. Because for constitutional delay, we have a different criteria. For short stature, we have a different criteria. We can differentiate only by the bone age, chronological age, and height age, and weight age, many disorders. So from my perspective, Grulich Pyle appears to be much better, sir, and I'm more comfortable with it.
Dr. Rahul, Dr. Rajiv, Dr. Mohan, which atlas do you use?
We are commonly using Grulich and Pyle only.
So that means there is a change in AIIMS New Delhi as well, because I trained with TW2.
So we also do Grulich and Pyle, sir.
Yeah, so that I wonder when that shift occurred now. So maybe when TW3 came, but we need to find out, and that it would be interesting also to see why the change occurred in that department. Though across the country, I see that Grulich Pyle is more popular now. When you
I think it's more easier. I think it's more easier and quicker in the clinic.
Exactly. TW3 takes a lot of time.
Moreover, digital X-ray also, we have some handbooks also. I think I am also using some of the easier ways, because on my mobile I have some handbooks which may have a digital, because digital X-rays are different. So I think the newer, there are so many versions of digital X-ray handbooks also. I can familiarize with one of them.
Grulich Pyle is very easy to do with the digital, and maybe work for Dr. Rahul offline would be to find out in which year this shift occurred in All India Institute department, when they shifted from TW to GP. But so now we've talked of height age, weight age, we've talked of bone age as well. And we are saying that short stature is quite complex. It's not a short story. You can't finish it in a few minutes. And let's add another googly, something that our students are afraid of in exams. But of course, this is non-violence week going on. What about dental age? How important is dental age? Dr. Mohan, the question to you is the average pediatrician cognizant of dental age and its importance in differential diagnosis?
Yeah, dental age is very much important, because sometimes, you know, the primary dental transformation is also somewhat dependent on the nutrition status also, and also hormonal status. So I think the pediatrician usually asks them in 5 years of age whether they have the new set of teeth coming up, and around 10 years of age, what is the status of that new set of teeth. By the 13 years of age, they check whether wisdom tooth is there or not. And around 18 years of age, when they are prepared to leave them to adult people, just checking whether everything is fine or not. So I think they don't check everywhere what all tooth they have or they are not, but generally they just find out how much they are having teeth, how much eruptions are there, and whether they have supernumerary or some teeth which is impacted teeth, we call them. Some they can also have an impact on the mandible and the progression of the articulation and all. So the person's confidence depends on the smile of the individual, and height also adds to that, because previously we thought height is only having only a social angle to it. There is also a personal esteem, because I think when you just tell me about teeth, showing the teeth sometimes may be difficult for a person, but the height is one of the things which readily noticed by anybody from the distance. So having a short child in the family carries a lot of stigma to the family and the individual also.
So, and one nice thing is I'd like to thank all our panelists. We are doing very well for time today. We've talked about history taking, we've talked about investigations, and one by one, we are uncovering all the various, all the fine details of short stature evaluation. And we've seen that dental age and dental health both are important. So we have to take a history. And that means we should be aware of the physiology of dental growth. When do the teeth, when do the milk teeth come out, and when do the permanent teeth erupt? We should be aware of all these dates, and dental age is something we should be aware of. Supposing you are working in a periphery where even an X-ray is not available, just hypothetically, then you can just examine your patient. Dental age will give you a lot of ideas. Let's come to investigations now, and let's talk about a few questions. All these questions will have simple answers. We'll just go through them, and then we'll request our panelists to sort of, wrap up the entire session with their take-home comments. So let's talk about, in this order, first about nutritional causes of short stature. Then we'll talk about non-endocrine causes, medical, metabolic, and then we'll go on to endocrine causes. And now we are on investigations. If Dr. Rajiv, you'd like to begin, the nutritional status, any investigations that we can do in children, would it make sense to do a serum albumin, serum protein? Would it make sense to do a serum vitamin D in every patient or not?
So, sir, I would say that doing vitamin D, vitamin B12 may be important, but I think generally we should start with little more common things. We need to look at what their hemoglobin looks like. And as you said, we need to look at what their albumin looks like, what their calcium looks like, because they would also give you an overall good assessment of what their nutritional status is. Vitamin D and vitamin B12 we've seen is very, very commonly deficient in general population. So they may be deficient, but whether they are actually contributing to short stature or not may be a little difficult. So generally, until unless I've got some specific things to look for, or I specifically suspect something, I routinely do not do vitamin D and B12 in other children. As far as nutrition is concerned, if we are from growth chart, if we are suspecting that there is nutritional issues there, so then apart from doing normal routine, these CBC, their LFT, and I would definitely go for testing for celiac disease, anti-TTG, IgA antibody, and a total IgA antibody combination.
Yeah. So we'll
just look at for the
nutrition. We'll come to that. So the point is that whether you're handling short stature or any other disease in the clinic, nutritional optimization is a must. Until you optimize the nutrition, nothing else is going to work. So even if the patient has growth hormone deficiency, or the patient has, let us say, central hypothyroidism or panhypopit, even then nutritional optimization is required. So the Indian data, Dr. Rahul, shows that 67% of our women and 50% of our children are iron deficient. They are anemic. Does this reflect in the endocrine clinic as well? Do you feel that 2/3 of all women in the endocrine clinic and 1/2 of all children and maybe around 1/3 of all men in your clinic have anemia?
So, sir, if we use a strict criteria that are recommended by WHO of 12 gram per deciliter and 30 gram per deciliter for women and men respectively, we might actually be seeing these figures in clinical practices.
Now let's come to children only. We need to optimize them for nutrition. So maybe Dr. Mohan would like to take this. In the pediatrics clinic, what is the routine work that you do to prevent anemia, to treat anemia? And now nutritional anemia is common. So how do I find out whether it is folate deficiency, B12 deficiency, or iron deficiency? All are nutritional.
Yeah. So I think hemoglobin of 12 is a must for a person to by the age of 12 years of age. That's what we tell, 12 by 12. But I think in the children, we want a higher or a better values. So anemia should be definitely addressed at the earlier point. One thing we do is take a systematic history and we find out whether the tongue is also pale, the palms are pale or not. Sometimes they not be reflecting on the face also. So we have to take a proper history as well. Then we do deworming because one of the issues which we face is that people tend to mouth a lot sometimes at the younger age because they take to eat from the ground, sometimes the pollen. And maybe even though nutrition, we are still having a good standards, we still have some issues with the nutrition, with the worms. So worm infestation, we do a deworming in the timely period. So maybe 6 monthly after the age of 2 years, we usually try to do it. In the schools, they have a portion program also where midday meals they are giving for the free of cost. So I think the way to go is that we have to optimize the nutrition right from the school and we have to continue that in the home. And when they come to the clinic, take at least 2-3 minutes to spend on what they have eaten the last few weeks. That also adds up. If you suggest some iron containing vegetables, or they may not like it. But if you suggest jaggery, because jaggery we call sharkara in our place. So jaggery is one of the favorite because they have some groundnut with jaggery, some eatables. So that's actually older type, but nowadays children like to have some commercial elements. But I think jaggery containing may be one of the ideas which we can implement in a local practice.
And an English word which I learned recently is allotriophagia, which means a love for foreign food. That means like pica, for example. So that is allotriophagia. And then a new term that we coined was allotriodipsia, which means a love for foreign beverages. An example would be maybe a love for ice cold water, as you can see in some pituitary diseases. So we are talking of nutrition, and now we are talking of investigations. And Dr. Rajiv did mention celiac disease. Now, the question, Dr. Jay, celiac, multiple questions. Is Dr. Rajiv right in saying that celiac disease causes short stature through nutritional mechanisms? Is that right? Is it partly right?
So I think basically when I'm talking about my town, Dr. Mohan told that celiac is not so commonly seen there. But on an off and on basis, just incidentally we get an celiac done. Say just hemoglobin was around 10. We suspected, okay, let's get this investigation, and it comes out to be positive. Many patients are asymptomatic. Just quoting certain examples of mine, recently I saw a very short child with only a mild degree of anemia, around it was 10 to 11 gram of hemoglobin, occasional pain abdomen, that was his only history, nothing else. All the parents normal, his height was slightly on the lower side, but when I got a screening, the celiac came out to be positive. And another history of a delayed puberty. So patient didn't have mustaches till 18 years of age. Incidentally, he came and he didn't have any abdominal symptoms. But the celiac came out to be positive. As soon as we withdrawn the gluten, he entered into a normal puberty. So wide is the spectrum of presentation of celiac. We routinely see in our thyroid patients also, who have a huge fluctuation in their doses of thyroid. Suddenly they are on 200 and suddenly we have to shift to 100. So celiac is a silent killer on that part also.
Yeah.
So from my perspective, nutritionally, celiac is very important because it causes malabsorption. So malabsorption not only to the single component, it is a multiple component. When we are talking about, it may be micronutrients, it may be minerals, it may be macronutrients. So all these deficiency clubbed together is the basic cause behind this malabsorption due to celiac. So only a gluten withdrawal can take care. Yes.
And Dr. Rahul, there is supposed to be a latitude gradient in the sense that the further away you move from the equator, the more frequent all autoimmune diseases are. From your knowledge of Indian epidemiology, Do you think this is true for celiac disease? Is it true for type 1 diabetes, for vitiligo, for other autoimmune diseases?
Okay, so sir, as far as celiac is concerned, I mean, there has been some suggestion of a north-south divide, with celiacs being more common in north as compared to the southern cities. And what would be the exact reasons behind it remains elusive as of now.
This is true, but for type 1 diabetes as well. The
Yes.
further away, and it's not only within India, the further north that you go, let us say you go to Finland, you go to Denmark or Norway, you will find a very high incidence of type 1 diabetes there. And when you come down towards southern Europe, the incidence of type 1 diabetes also comes down. So these are things to ponder over.
Yes, so one of the postulated reasons behind
Sir,
is the hygiene
north
hypothesis.
and south division can be because in the north we consume more of gluten, in the south more of rice is there. Whether that can be a cause behind, sir?
That is a potential, and Dr. Jay is right in the middle, so we will ask him to answer next time. But Dr. Rahul, will you complete? You wanted to say something.
Okay, so one of the postulated reasons behind this is the hygiene hypothesis, that as more socially or economically advanced you are, lesser you are exposed to the immune environmental challenges leading to an immature immune system.
Right. Another question related to celiac, and we are on investigations now. So when we were students, we were taught that if the bone age is delayed, it is an endocrine disorder. If the bone age is not delayed, it is a non-endocrine disorder of short stature. The only exception is celiac disease. Does this hold true today?
I think to a certain extent, the delay in bone age too is parallels with the severity of the illnesses. If we more often than not in very severe illness do not estimate a bone age because the cause is very much evident with us. And if we do, we are likely to have a significant delay in bone age in those cases as well. It's only in the mild chronic illnesses like worm infestations or celiac presenting as a monosymptomatic presentation as short stature. In those scenarios where we may not have a delay in bone age as high as what we see in the endocrine disorders, like let's say hypothyroidism or an isolated growth hormone deficiency or a multiple pituitary hormone deficiency.
Even what I would like to say is that earlier, this is conventional teaching, conventional training. Things were sort of taught in black and white, but now we have better quality investigations. 25 years ago, the quality of our thyroid assays, the TTG, the thyroid antibodies, we used to do TMA. So all these were not very good. Now that you have better quality investigations, now you find such a huge spectrum of permutations, combinations. So it is very rare that you will have absolute black and white statements for anything. For example, you cannot have a black and white statement that everyone with celiac disease will have abdominal pain, or everyone with celiac disease will have a delayed bone age or delayed puberty. It is such a wide spectrum, and you need to have that high index of suspicion. So we've talked about celiac disease. A few more questions. Dr. Mohan, I have a patient with short stature. I did the height and I did the weight charting. Obviously, there is short stature. Nutrition seems okay. I want to rule out thyroid. Is a TSH enough? That's the question.
So TSH is not at all enough for a person when you are evaluating for cause. We have to do a T4, T3 if possible, but I think we do a free T4 ideally if you have a good quality assay, because that estimates the actually bioavailable thyroid in the circulation. And we know that there are some presentations of thyroid which can also have some not symptomatic also. So sometimes we have to screen when you have a just mild symptom, constipation or lethargy may not be there. But some symptoms which are very typical are puffiness of face, pedal edema, some things which we can easily pick up in our practice. But goiter, the goiter is one of the easier things which we can notice, and it also has a physiological component in it. So I think doing a free T4 may help in the full diagnosis, and sometimes you have to repeat the assay, and sometimes you know that the TSH, if it is more than 10, only merits treatment also. So we need to know a complete profile. And if you have suspect of central causes, definitely we should do a free T4 and T3 also.
Because central will also be there. Two questions for Dr. Jay and Dr. Rajiv. Take them in whatever order you want. A patient came with short stature. The general physician had advised a random growth hormone. He told the child also, you must get up at 7 a.m., you must remain hungry, and then you go to the lab at 9 a.m. and get the fasting serum growth hormone done. And this happens very commonly in practice. So we have multiple questions. If you can take one by one, all the panelists. Number one, is this necessary? That's first question. Number two, is it of any relevance? Is it of any value? Number three, is there a hierarchy before you check for growth hormone? What do you do about the sex steroids in a child who's maybe 13, 14 years old? How do you check growth hormone? And then the last one, maybe that will come to Dr. Mohan by the time all of you have completed. What is the right way of checking for growth hormone deficiency?
I will take on the growth hormone perspective. It's very common basically when the pediatrician gets a growth hormone that comes out to be 0.3, maybe a random, maybe a fasting, and he refers that the child is short because of growth hormone deficiency. This is an endocrine field. So that was our basic teaching in endocrinology. Provocative testing is a must, and Mohan will definitely delineate on that part. So that testing should be on a proper manner. Whenever we ask for a growth hormone, we say there should be two cumbersome things. One is physical activity, either step up and down for at least 5 to 10 minutes. So that is a dynamic test. And then certain, maybe Argamin or maybe any other injectable, whatever options are available to you for growth hormone testing. So that is an ideal. If suppose you want to test growth hormone deficiency where you are strongly suspecting growth hormone deficiency still, before that, what you were talking about, that hierarchy. So all the nutritional, all the discussions which we had previously in this session should be ruled out, whether it is celiac, whether it is any constitutionally named growth and puberty, whether it may be a nutritional issues, it may be anemia, or it may be any other cause. Then only you proceed for growth hormone deficiency testing. And if you want to also, the nutrition is another very important thing to be ensured, because suppose we are being taught that you should get an IGF-1 done 2 simultaneously. So an IGF-1 also needs a age standard curves. Also, it needs a good nutrition. So these are very important things which should be taken care of, that growth hormone should not be rushed to, and you should get all the basic profiles from thyroid to celiac to every screen before going to growth hormone. And the hierarchy should be maintained. That's another very important thing. Pertaining to what you told about the pubertal, peripubertal time, you definitely have to prime with the testosterone or the estrogen to a peripubertal female. Otherwise, the growth hormone may give you a false result. So these are certain points from my side. So never rush, because growth hormone therapy itself is costly. And once you are labeling growth hormone deficiency, you need a multitude of things to be done. So before that, many simple things come in play. Yes.
Dr. Rajiv, we have a total of 3 minutes left, and we have 2-3 questions also left. So this priming for peripubertal children before you check growth hormone, what do you follow in practice?
So, sir, before that, I think I would like to say that we should discourage testing randomly for growth hormone.
Oh, yeah, not only discourage, we should, mandatory. Discourage is a very soft word.
Right. So basically, because growth hormone has variations, so they would be keep going on up and down. So one message should go loud and clear that testing for random growth hormone gives us no clue about whether the child is growth hormone deficient or not. As for the priming is concerned, I think I agree with Dr. J that anybody who comes in a peripubertal age group, then we need to look at their we need to prime them with their sex hormones, and then only after that we do the growth hormone provocation test for them.
Dr. Rahul, would you like to add to this? Any other caveats that you should have in mind? Is there any situation where growth hormone testing is contraindicated?
So the growth hormone stimulation tests that we do, and especially in children who are less than 1 year of age, those with a prior history of seizures or an partially treated or untreated multiple pituitary hormone deficiencies. In these scenarios, we should be doing it cautiously, especially the insulin-induced hypoglycemia that more often than not has been given away by most of the centers.
And just follow the stepwise hierarchy. First first nutrition, then metabolism and medical, then adrenal steroids, whether you're thinking pituitary or adrenal, but adrenal sufficiency should be maintained. Then maybe thyroid, and then you come to sex steroids, then the pubertal, if it is required, depending on the age of the child, and then growth hormone. That's stepwise. Dr. Mohan, we have just 1 minute left. A few pointers on how to do a growth hormone stimulation in the periphery. you do not have facilities for an insulin tolerance test.
Yeah, so I think insulin tolerance is not available. We usually go by giving a clonidine stimulation test or like glucagon test. And actually, we should do a physiological thing along with the pharmacological thing, because then only we get the maximum effect of the growth hormone stimulus. So we have got medicines available like that. So clonidine is available. So we have to give at least 0.15 milligram per micrometer squared, and we should give them at least at the proper time of the day. And we should actually check the values after 30 minutes, 15 minutes, 30 minutes, 45 and 1 hour if possible. 90-minute sample is ideally required, because in our center, we have to fast them and do them. We don't do every time, but ideally if the person tolerates them, we should do. And some physiological stimulus also should be done along with that. So that may be some cycling, or maybe continuing them on fasting, and sometimes running also helps them. But I think those things cannot be done in an ideal situation. But if you are doing it, then you repeat them if you have a suspicion, because if you are getting a value, we should inform the lab ahead of time also. Because I had a situation where the lab did not know that these tests were done in a child which having so much importance, and they messed up the sample also. So periphery situation, we have to inform the lab well ahead of time to collect the sample correctly, and we should also do a repeat sampling and labeling them correctly, because whatever time of the day we have taken, we should label them correctly. And when you get the report, be very sure that they are actually coming in the right order also. Then only we know. So we had a nadir value. If it is at least more than 5, we tell them it's pass mark. If it is across the 10, it is very good. So if it is below then we should tell it insufficient and may need a repeat test also.
You may need a repeat, right? It's 8:15, and I'd like to thank all our panelists. Our work for today, our task was to talk about the history taking, the examination, and the investigations for short stature. Of course, you cannot complete everything in 45 minutes, but the way our panelists have discussed and debated, they have helped us open this wide spectrum. And I, for one, can say as an individual, they've helped me open my brain. You know, all those dormant neurons, I still have some of them. And I'm waiting for Dr. Rajiv to bring out a nice medicine for Alzheimer's. Until he brings it out, I'll manage. I'll stay. But they've helped us stimulate our thought process, and they've helped us understand that short stature is not so simple. We will request 1 minute more from the organizers, and we'll request all our panelists one by one to just share a take-home message in 15 seconds. May I begin with Dr. Rahul, please?
Okay, so my single most important message for evaluation of short stature is proper measurement of height and weight over a period of time with correct plotting on growth charts in accordance to the date of birth and chronological age. That gives us answers to most of the diagnosis even before any investigation is done.
So height, weight, measurement, height, weight, monitoring, and also interpretation. Thank you, Dr. Rahul. Dr. Jay, please.
Yes, sir. Other than that anthropometric data, always give an example like Dr. Sanjay Kalra, sir. He's a perfect examiner, so at least we are perfectly happy as a student of him. This session was very beautiful, sir. My point will be, other than anthropometric data, never rush for major investigations until you rule out simple investigations. Just rule out thyroid, just rule out celiac, just rule out nutrition. These are very, very important things. Then you switch to the endocrine causes. Majority of the growth people who are referred for short stature are having nothing. The reason is they are not properly evaluated. So a proper evaluation will give you a much easier task. Then definitely the endocrine cause can be taken care of. Thank you, sir.
So thank you. So measurement and monitoring, like Dr. Rahul said, and then a rational approach and go stepwise. You don't have to do everything in one day. You can tell your patient that I am with you, I am your endocrinologist, I am your pediatrician, I will be with you for the rest of your life. So let's go slow and let's run this marathon. And Dr. Mohan, would you like to add to this, please?
Yeah, just wanted to add that the framework lies in history, examination, and charts, and do the salient labs only if required, and bone age, because bone age we can distinguish so many things. So if you don't know to do it, please ask your radiologist also, as sir has told. Radiologist often has an experience, they help you. Advanced imaging and genetic studies are not required for every case. So we have to minimize them. And I think the last point is timely referral, because I had so many cases of Turner syndrome people who are referred at around 15 years of age. They had a diagnosis readily available, but they did not refer them. So I think the message is very clear. Endocrine awareness is my message, sir.
Thank you. And Dr. Rajiv, if you could sum up for all of us, please.
Yeah, so thank you, sir, for this incredible session. And then I would just like to sum up by saying that, of course, now we know the steps as to how to correctly delineate the diagnosis of of somebody with short stature, or at least the steps to make the diagnosis. Not every short stature is GHD, and growth hormone need to be evaluated in a very, very proper manner. It's a temperature sensitive hormone. There are chances of over-diagnosing GHD in periphery are very, very high. So and it's as Dr. J rightly pointed out, it's a costly therapy. So we need to look at very, very rationally who needs it and who doesn't need it. So making a proper diagnosis by using history, by using examination, by using lab is beyond any comparison in any of other fields as compared to this. So thank you so much.
Thank you to everyone for being with us. And Dr. Deepak Khandelwal, we apologize for being 5 minutes behind time.
Thank you, sir.
Thank you for your indulgence.
He switches on his video if we are behind our time. So his being there is enough reprimand for us.
He is the master examiner.
Wonderful session, and I also learned a lot of new things this time, and the discussion was really very wonderful. So I think before I go to question and answers, I would like to have any quick comments from our last chairpersons, Dr. Nyaya Bhai Gupta, Dr. Dinesh Yadav, or Dr. Mukesh Verma. If you want to make any quick comments or any important message there from your side, Dinesh or Dr. Nyaya or Dr. Mukesh Verma, please. Okay, if there's no inputs, then sir, just to bring to your kind knowledge, I think we have delegates joining from our places also. We have delegates from Siliguri, from Kashmir and other parts from southern India also. I think one question you have already covered very well. Practical approach in terms of laboratory investigations. If somebody is working in the periphery, I think this part is covered very well. It was from Siliguri from Dr. Devaragya. I think there are two questions for Dr. Ashima. I will wait for her because I think she's driving. So I think maybe
we acknowledge also Dr. Mumin Hussain Bhatt from Srinagar.
Ashima, can you hear us?
Yes, I can hear you.
Ashima, I think there was one question related to any growth app that can be downloaded on the phone, and parents or the clinicians, they can use the phone.
So what I know is probably the IAP growth charts work also on the iOS, but not the Anthrocal. And there is one more app which was told to me for the iOS, but that is not based on the Indian data. So I would advise not using that.
So then I think Dr. Rajiv Sumla
I'll just interrupt.
very carefully.
There is an IAP growth chart, which is work on even the Android app also. So if I'm sure, it comes with the name of IAP growth chart only.
IAP growth chart works, but the Anthrocal doesn't work. So the ST score calculation app doesn't work on the iOS. The growth chart works. And
Yes.
The problem with the IAP growth chart on the phone is it will only give you a single point reading. It does not plot growth as growth velocity. So okay for a quick screening, but I somehow feel that the amount of time we waste opening the app and entering and then seeing the data, a physical growth chart does more wonders than that app.
That's
So
true.
personally, I prefer the Anthrocal or using the physical growth chart.
Thank you, Ashima
Yeah.
and Vinit.
So
I think
people who are only on iOS, use the growth chart. Thank you.
fine. So Rajiv is listening very carefully. He's masters of all the technology in endocrinology, so I'm sure he will come up with some, fantastic maybe app in next 1 to 2 years. So Rajiv, this is the next assignment for you. Ashima, just one more question. I think it was from Dr. Bhatt from Srinagar. Does BMI curve follow a Gaussian distribution? Ashima, can you hear?
Yes.
Does BMI curve follow a Gaussian distribution?
So for that, I think any population parameter is supposed to follow Gaussian distribution, but because BMI is dependent on many environmental factors and is very dynamic. So probably that is why the reports coming for even the NFHS 5 data has shown an increase in the overweight and obesity, way more than it was reported in the earlier NFHS survey. So probably that is the reason there is some concern of whether it is following the Gaussian distribution or not. But theoretically, yes, it should.
Thank you. Thank you. Thank you Ashwini, for answering all the questions. So I think we can go to the next session. And for next session, we have, let me just, okay. So next session is basically interesting talk by Dr. Alpesh Goel on the advances in the treatment of pediatric growth hormone deficiency. We have very two learned chairpersons, Dr. Yogesh Parekh from Gujarat. He has been currently at Government Medical College Surat. He is very renowned academician and pediatrician working there, member of almost every pediatric committee, that is there in the Gujarat. Then we have Dr. Satish Sharma, again a very renowned pediatrician working in Rohtak, a very academic person in working in medical director, Arcus Super Specialty Medical Center at Rohtak. So I welcome Dr. Yogesh Parekh and Dr. Satish Sharma sir. And speaker is Dr. Alpesh Goel. I know him very personally, assistant professor in Department of Endocrinology at AIIMS. Very learned, very academic person. You can see very reputed awards to his credit, whether it is A.V. Gandhi Award or ML Big Medal Award for Best Clinical Research or MMS House Award for Best Outgoing DM student from AIIMS. So I invite Dr. Alpesh for his talk. Thank you.
Thank you, sir, for the kind introduction. Is my screen visible, sir?
Yes, Alpesh.
Okay. Thank you so much. I would like to thank Team Speed for organizing this meeting, which actually provides us with an opportunity to engage in clinically meaningful discussion. So the topic for me is advances in treatment of pediatric growth hormone deficiency, and I'll also try and cover some basic aspects of treatment of pediatric growth hormone deficiency. So as has already been discussed in the previous talk, there are numerous causes of short stature, and disorders of growth hormone and IGF-1 excess are not the most common ones. They are important, but they are the less common ones. So amongst the disorders of growth hormone and IGF-1 excess, growth hormone deficiency is by far the most common cause. It could be congenital or it could be acquired, say due to an intracranial tumor like a craniopharyngioma. And growth hormone deficiency could be isolated or could be a part of multiple pituitary hormone deficiencies. And we know that growth hormone is approved for use for indications other than growth hormone deficiency. And that is something that will be discussed in a subsequent panel as well. Now, when we come to pediatric growth hormone deficiency treatment, we know that treatment is on the basis of a well-made diagnosis, which is based on good anthropometric examination, a good lab support, and you use subcutaneous injection of somatropin or human growth hormone, because the action of growth hormone is species specific. So you can only use human growth hormone in this regard. The recombinant form of human growth hormone has been available since 1985, and it has superseded the pituitary growth hormone that was used but was discontinued due to emergence of a particular prion disease. We have innovator molecules such as norditropin, but we also, once patent expired, we have biosimilar molecules such as Hedon, and it has been shown in various studies from outside India and from India, including from our center, that there is no difference in efficacy and safety of innovator molecules and biosimilar molecules, while the biosimilar molecules provide a good cost effectiveness. The biopotency of growth hormone, as we know, each 1 milligram of growth hormone equates to about 3 international units. The dose that we start with is roughly 0.2 milligrams per kg per week, and then we can go up to 0.3 milligrams per kg per week. If we equate in micrograms per kg, it will be roughly 25 to 50 micrograms per kg. It has to be administered on all days of a week, and it is administered at night, typically between 7 and 9 p.m. because we want to mimic the physiology of growth hormone where it peaks in the night time. Now, it has been shown that if you use same weekly dose, but you employ intermittent dosing, that you use 3/7 dosing, same dose you administer on 3 days or 6 days, it has been shown with the help of well-designed RCTs that this approach is less effective. So the message is that it has to be a daily growth hormone therapy. Maximum efficacy is seen in first year of treatment, and then there is progressive waning, and it has been reported from large databases that the growth velocity is typically between 10 and 12 centimeters during first year, and then it declines to somewhere between 7 to 9 centimeters during second and third year. You would want to continue till you reach the near adult height, which is typically defined as a growth velocity of less than 2 to 2.5 centimeters per year, or when there is adequate skeletal maturation, which is defined as bone age of more than 14 years in girls and more than 17 years in boys. Now, what are the data from large databases, being Kabi International Growth Study or National Cooperative Growth Study, which show that average final height is somewhere between -0.8 to -1.3 SDS. That is, average final height that is reached is well within the normal for the population. There are certain predictors of response to growth hormone therapy because the response can be a little variable depending on when you start the treatment and which kind of patient you start the treatment. So there are various predictors. So these include first year height velocity, which is a very good marker of overall height gain with growth hormone therapy. Earlier the age at which you start treatment, better is the treatment response. Especially treatment in prepubertal years is a predictor of very good height response. Severity of growth hormone deficiency. If you have severe growth hormone deficiency to begin with, better will be the response. Same is being reflected by baseline height deficit, height minus NPH SDS, which is again reflective of severity of growth hormone deficiency. Growth hormone dose again is important. Growth hormone receptor function is very important, and it's been shown that certain polymorphism favorably are favorable in terms of growth hormone efficacy, and weight and birth weight SDS have also been shown to positively correlate with response to growth hormone treatment. Now, I'll share some data from our center on response to growth hormone therapy, and then I'll also compare this with studies which have been done in Indian context. So this was a study, a retrospective study, where we evaluated 99 children with growth hormone deficiency who had received growth hormone therapy for at least 1 year. And we saw that at the baseline, the presentation was somewhere around 12 years of age with a height SDS of -4 and a bone age delay of around 4 years. So the age at presentation, if we compare with Caucasian studies, which is around 9 to 10 years, so we can see that in our setting, the presentation is actually later. And once we start them on growth hormone treatment, the first year height velocity is somewhere around 10.6 centimeters, which goes down to 8.7 during second year and 7.9 centimeters per year during third year. And there is progressive waning of the effect. But what is heartening to see is that when you start with -4 SDS, by year 3 or 4, you are reaching somewhere around -1.9 SDS, which means that you are reaching to a diagnosis where you are no longer short for the population. Now, if we compare with other studies, we see that there are different studies which have been performed right from year 1991 till 2019. Most of the studies have used a population of growth hormone deficiency. However, some studies have also used chronic kidney disease and Turner syndrome patients, and the sample size have varied from between 15 to 99. And if you see, the first year height velocity has varied somewhere between 8 to 12 centimeters per year. And the possible reasons for this variation could be the age at which treatment has been started, the degree of growth hormone deficiency, and the baseline height SDS or severity of growth hormone deficiency, which are all predictors of growth hormone response. When you come to the monitoring, it is important. Once you start patient on growth hormone therapy, you should monitor for adverse effects. I will not go into detail of those. Anthropometric examination is very important. You do serial growth monitoring, plot it on a growth chart as has been discussed in previous sessions. You do a growth velocity, and ideally a growth velocity should be calculated over a 6-month period. Skeletal maturation using bone age assessment should be done annually. Pubertal status assessment should be done periodically. Serum IGF-1 is measured on a 6 to 12 monthly basis, and the major aspect of measuring serum IGF-1 is to just see that it is not exceeding the upper limit of normal, so that you don't end up with adverse effects. If it is generally not used for dose titration. It is clinical response which is used for dose titration. Pre-T4 is again important to be measured after 3 months of therapy, because there can be some unmasking of central hypothyroidism, and then it has to be repeated at 6 to 12 months interval, and other pituitary hormones as will be indicated if there is a patient with multiple pituitary hormone deficiency. Now, there is something called as inadequate response to growth hormone therapy. And what is that? If you don't achieve the optimal growth velocity, which is expected, or it is roughly, it can be defined that if you don't gain a height SDS of at least 0.25 after 1 year of growth hormone therapy, that is something that is considered as inadequate response. And there could be various issues, non-adherence, technique or preparation issues, especially when you are using lyophilized form. Presence of central hypothyroidism, subclinical hypothyroidism, coexistent systemic disease, use of excessive glucocorticoid therapy when patient is having concomitant adrenal insufficiency, spinal irradiation, which may be an important factor in pediatric cancer survivors. There is already skeletal maturation which has occurred, anti-GH antibodies, which is a rare phenomenon, and finally, your diagnosis may not be correct in first place. So all of these are important when you see inadequate response to growth hormone therapy. When I move to advances in treatment of growth hormone deficiency, we know that pituitary human growth hormone has been in use since 1958. And then we had introduction of recombinant human growth hormone therapy in 1985. But it has been seen that in real world, there are issues with adherence and treatment burden, and non-adherence rates of up to 80% have been reported in real world studies. So the endeavor of scientific community from the very beginning has been to reduce the treatment burden using long-acting growth hormone preparations, which mandate lesser frequency. In this case, it could be once a week therapy. So even when we were using pituitary growth hormone in 1979, a study of growth hormone gelatin, where growth hormones incorporated in gelatin was tried to improve the half-life of growth hormone. Subsequently, growth hormone, long-acting growth hormone formulations have come up, which could either be depot formulations such as neutropin depot or eutropin plus, a pegylated growth hormone, which is gintrolon, or somapacitan, which is a growth hormone that has been modified to increase its albumin binding, a somatrogon, which is a recombinant human growth hormone, which is fused to C-terminal peptides of beta-HCG, and finally, lonapag-somatropin, which is a prodrug growth hormone that increases the duration of action. So amongst these, the three last that I have said, somapacitan, somatrogon, and lonapag-somatropin, have shown non-inferiority to daily growth hormone in terms of childhood growth hormone deficiency. And the last molecule, that is Skytrofa, is the latest one, which has been, this is the only molecule which has been US FDA approved, and I'll discuss this in more detail. So this molecule, which is a long-acting growth hormone molecule, which is also called as transformed human growth hormone, it consists of somatropin, or human growth hormone, which is in inactive state, is linked by a linker to an inactive carrier, which is also known as transferrin carrier. And this carrier consists of methoxypolyethylene glycol. Now, what this carrier does is it shields the growth hormone from receptor-mediated clearance and renal clearance. So the half-life of growth hormone increases from usual 2 to 3 hours during subcutaneous injection to 25 hours. And this enables once a week administration of this molecule. Now, what happens is that there is a cleavage of linker in physiological conditions, and growth hormone is released slowly, and it acts on the receptor, while the carrier is cleared through the renal route, and a mild amount of clearance is also done through hepatobiliary route. So this is how this molecule works, and it increases the half-life of this molecule and enables once a week administration. So there are data from phase 3 height trial for this molecule, which led to approval by US FDA for this molecule. And this was a multi-center open-labeled randomized controlled trial, which was performed in 15 countries. And here authors had treated 161 prepubertal growth hormone deficient children who were randomized in 2:1 ratio to either long-acting growth hormone preparation or equivalent dose of daily human growth hormone. And the primary endpoint was annualized height velocity at week 52. This is the consort diagram, which showed that around 104 patients completed treatment in the active group and 55 in the comparator arm. And the annualized height velocity at 52 weeks was 11.2 centimeters per year in the treatment arm and 10.3 centimeters per year in the comparator arm, which was daily human growth hormone. And this not only reached statistical significance for non-inferiority, but also for superiority. And there was comparable tolerability in terms of adverse effects and immunogenicity in terms of anti-growth hormone antibodies. In fact, there were no neutralizing anti-growth hormone antibodies that were seen in the either arm. And if you can see this height SDS curves, if this is the blue one is the daily somatropin or daily growth hormone group, and the green one are the weekly long-acting growth hormone group. And as you can see, the curves have separated at 26 weeks very significantly, and at 52 weeks there is a significant difference in height SDS in terms of the height gain. So we can see that this molecule was not only found to be non-inferior, but it was also found to be superior to the daily growth hormone therapy. And this was then subsequently approved for pediatric growth hormone deficiency treatment. And it's been approved in children 1 year or older with growth hormone deficiency who have a weight of more than 11.5 kgs. Now, this molecule is still not available in India, but maybe in future we may see once weekly growth hormone therapy coming up. Now, the advantages could be that this could reduce the treatment burden. There may be improvement in adherence. There may be improvement in quality of life, but we need to see long-term data as well and the cost effectiveness. So the take-home messages from this presentation are that daily growth hormone therapy remains a standard of care for pediatric growth hormone deficiency. You need to carefully diagnose growth hormone deficiency and then start treatment after discussing the cost issues. There is a need for close monitoring. You need to consider predictors of response, which may explain some variability in response, and also suspect inadequate response and appropriately investigate causes of inadequate response. Definitely, long-acting growth hormone formulations, they have been coming up in recent years, and they have potential to improve adherence and reduce treatment burden. However, we do need a long-term surveillance on safety, efficacy, and cost effectiveness with these molecules, as we had with the daily growth hormone molecules that are readily available to us. So thank you so much. I'll stop here and over to chairpersons and all.
Thank you, Alpesh. It was a wonderful talk. I think very quick summary of growth hormone treatment, very fantastic data that you presented from AIIMS, and then sort of recent advances and longer acting preparation. So any quick comments from our chairpersons, Dr. Satish Sharma or Dr. Yogesh Parekh sir, any comments from your side? Dr. Satish, any comments?
Hello? Hello?
Hello, sir. Yes, we can hear you.
Hello?
Dr. Satish?
Hello?
Satish, sir, are you able to hear us?
Hello?
Satish, sir, you are audible, sir.
Hello? Am I audible?
Yes, yes,
Yes,
sir.
sir.
Hello?
Yes,
You are
sir.
audible,
Yes,
sir.
you're audible.
Okay. Thank you, Dr. Alpesh Goyal, for your wonderful presentation and your insight into a particular long-acting growth hormone. And as you said, there poor, sometimes adherence may not be good, the compliance may not be good, and patients, they are fed up to giving, daily growth hormone injection. And this is a novel growth hormone, but the pharmacodynamic and pharmacokinetic of this molecule is definitely different. Its molecular structure and its chemistry is different than this regular this growth hormone. And to monitor this, I think IGF-1, earlier we used to say, and how to monitor that this is effective, is efficacy and the side effect. Still more and more data has to come. Then we cannot, even there is, whether the patient will be very happy to know that we have to take injection once a week. But we have to sensitize and make aware our physician that this long acting has come into the market and will take few years to become popular in the market. It's come and approval by the US FDA and the Indian DCGI. So how I mean to say IGF-1 to be done in such cases, because this is a pro-hormone and chemistry is different than the regular growth hormone. So I think IGF-1 is to be, I think, more relevant in such cases rather than earlier we used to have in regular growth hormone somatotropin.
Okay, sir, thank you. I think I'll first answer your concern. You're very right in saying that we need to have more data. In fact, there is some experience which has come up from US as well. And the authors have stated that in their experience, their clientage who have been offered this molecule, they are not very willing to take this up because of many reasons. One, that it is not still come up on their insurance provider list. Other thing is that most of the patients, they are very happy with the daily growth hormone therapy as well, and they have been seeing that it has been doing wonders for them. And there is the fear of change and cost effectiveness issues. So it's still a molecule in its infancy, but may take over the market in near future, provided there is cost effectiveness and good safety and efficacy data long term. Now, you made a very pertinent point about IGF-1, sir. Yes, this is a long-acting formulation, so we do expect peak and trough effect. So we, in this study as well, authors had measured peak IGF-1, which was evident at 2 to 3 days after injection. And then there is a nadir that is evident at 6 to 7 days. And then they have calculated the average IGF-1. So for clinical practice, what they have suggested is that you can measure IGF-1 at any day, but you have to rely on IGF-1 calculators based on pharmacokinetics data and pharmacodynamic data from phase 2 and phase 3 clinical trials. Or else they have suggested that you can use 4 to 5 day post-injection IGF-1, which will be reflective of average IGF-1. Now, there is a risk that IGF-1 may go up or during second and third days, just as we see with testosterone injections also, we can have supraphysiological levels. And whether that translates into long-term safety outcomes, that needs to be seen. Definitely, we'll need to have a close look on that as well.
Thank you, Alpesh. I think it was wonderful.
Yeah, one more point here.
Sir, I will just give me some time. I think we are running little short of time, so I will get back to you.
Okay. Thank you. Thank you. Nice explanation. Thank you very much.
Thank you, sir. So I think just one question that I would like to have this point of time. If Dr. Rajiv is there, Rajiv, there's a question by Dr. Bharat Bhushan from Delhi. What are the investigations that are to be done on the first visit? Once you have clearly documented short stature, what are the investigations to be done at the first visit? And when should the child be referred to the endocrinologist? So they are the two different questions. Dr. Rajiv, are you here? Or Dr. Sanjay Kalra, sir, Mohan, would you like to answer this question? Dr. Mohan?
Yeah, I'm here. Yeah. So
investigations on the first visit. Once you have clearly documented, yes, you have taken a history examination, the charting is done, and you are very convinced that yes, this is a case of short stature. So investigations in the first visit.
Yeah.
In the second part
So baseline.
Clearly said timely referral is important. So when the child should be referred to the endocrinologist.
Yes. So the baseline investigation should be a complete blood count, ESR. Then you do a thyroid function, TSH, free T4. Then we do the calcium profile. We do that. And if at all that we have suspecting our renal tubular acidosis, we do a ABG or VBG. We do it if everything is available or not. Then we have to do a specific conditions. We have to screen for them. If you have a suspicion for a celiac, we do a celiac screen. So basic profile still remains the same only. So that we have to do because IGF-1 may not be required in every case. So we do the baseline profile, and then accordingly we have to delineate each. And if at all we find something abnormal, then we have to go for the growth hormone stimulation test. So growth hormone should never be measured random because that is a pulsatile hormone, and it should be done only in a good center as well.
Thank you, Dr. Mohan. So I think we now come to the last part of the discussion, and I think that is very wonderful panel discussion that we will have. So for this panel, I will invite Professor Rajesh Khadgawat, sir. I think we have all learned pediatric endocrinology from him, and sir is the core person behind designing this program. He has been there for all these years for growth updates, and he is the person who has been guiding us to design these scientific programs and to execute these scientific programs. And then we have a panelist, Dr. Deep Datta, who is a renowned endocrinologist working in Dwarka. A lot of publications to his credit, member of a lot of academic society. He is very active in Endocrine Society of India. He is currently elected Joint Secretary for Endocrine Society of India. Dr. Vineet Surana, consultant endocrinologist working in Manipal Hospitals in Dwarka. Young, dynamic person, and he is the one person who is executing all of our SPEED conferences, SPEED1. Then we have Dr. Atul Dhingra from Ganganagar. He is again very dynamic person. They are in all kind of academic meetings, in all kind of executive bodies. We have Dr. Sachin Chittapwar, a very dynamic endocrinologist from Bhopal. He is leading endocrinologist in Central India. Faculty for many national, journal, and regional conferences, and many publications to his credit. So I welcome Khadgawat, sir. I welcome Dr. Deep Datta, Dr. Surana, Dr. Dhingra, and Dr. Chittapwar. So over to Dr. Khadgawat, sir.
Yeah, thank you, Deepak. So now, till now, we have learned how to define short stature, what are the investigations required, and how do we reach to the diagnosis of short stature. And if we do not find any specific cause, and we fulfill all conditions like we have euthyroid, there are no other issues. In that case, we can proceed for growth hormone deficiency. So Dr. Alpesh has beautifully elaborated all about growth hormone deficiency in a growth hormone deficient child. Now problem is we have done growth hormone stimulation test and there is no growth hormone deficiency. That means one of the values during growth hormone stimulation test crosses the mark of 10. So more than 10 nanogram per ml. If it's more than 10 nanogram per ml, then there is no growth hormone deficiency. However, if parents feel that child is very short, and now everybody likes that their children to be tall, so at times we have pressure of using growth hormone therapy in spite of having a normal growth hormone secretion or normal results of the growth hormone stimulation test. So, can we use growth hormone in conditions where growth hormone deficiency is not there? So, what are these conditions where we can use, and can we use in a normal child, which is the most pertinent question nowadays? So, we will answer in this discussion. So, we'll start first from the Dr. Deep. Dr. Deep, you are there?
Yes, sir. Very good evening, sir.
Hi, good evening, Deep. So can you let us know what are the conditions where there is no growth hormone deficiency and still people have used growth hormone, and these uses are approved by FDA apart from the growth hormone deficiency? And can you just in brief you can tell us in which year these growth hormone growth hormone uses were approved by the FDA? So if FDA approves it, more or less they are approved in other countries also. So what are these indications, Dr. Deep?
Yes, sir. So there are a lot of conditions where the kids are short, and in spite of lack of growth hormone deficiency, they have been found to improve height. But as a rule, the height outcomes have never been as impressive as we have seen with children with growth hormone deficiency. I think one of the most common conditions where we are using is in Turner syndrome, where we are using growth hormone. Apart from that, in patients with chronic disorder, underlying chronic kidney disease in kids who are very short, there has been some benefit has been seen. In kids with Prader-Willi syndrome, growth hormone has some metabolic or body composition benefits also apart from the height. Majority and certain skeletal dysplasias. It's a huge basket of disorders. The kids are short, they have disproportionate short stature, they may have short limb dwarfism or short trunk dwarfism, achondroplasia, hypochondroplasias. Growth hormone have been tried with varying success and varying outcomes, but yes, they have been tried with some minimal benefits in these kids.
Can you tell what are common conditions where growth hormone will used in a non-GH deficient conditions? Like you have said, its use is quite common in Turner syndrome. So do we need GH stimulation in these cases? If suppose if you see Turner syndrome, do we need to go for GH stimulation test, or we can go for directly for growth hormone therapy?
So in Turner syndrome, there are studies to show that earlier you start the growth hormone therapy better the height outcomes with regards to Turner specific growth charts. So it is important to plot the height in these kids on Turner specific growth charts. And even on a Turner specific growth chart, that particular girl is less than 3rd percentile. That means that child may be having some other secondary cause of short stature. In those kids, we need to rule out multiple pituitary hormone deficiency or growth hormone deficiency. Otherwise, we do not routinely do growth hormone stimulation test in a child with Turner syndrome.
And like you said, it can be used in chronic renal impairment or chronic renal failure. So can you specifically tell whether it's a pre-transplant or post-transplant also?
So thing is, it can be used in pre-transplant kids because there's underlying chronic disease. Many times there's a big waiting list in these kids. They may have to wait for years. Post-transplant kids also, the outcomes would be much better when it is continued in the post-transplant period also.
Okay, that's so. What Dr. Deep has told essentially is what are conditions where growth hormone can be used, even if there is no growth hormone deficiency. Dr. Vineet. Hi. So, Dr. Deep has started the Turner syndrome, and most common condition where we use growth hormone in spite of not having growth hormone deficiency is Turner syndrome. So, how essentially we diagnose Turner syndrome, when we should suspect for Turner syndrome, And once diagnosis is confirmed, so what are advantages of using growth hormone? Can you elaborate on that, and how long we have to use?
Okay, so the first thing is any child, especially the female child, coming with a short stature should be always suspected of having a Turner syndrome. We all know that the Turner features sometimes can be delayed, so we need to first do a good clinical examination to look for the Turner signs if they are there, and then the karyotype becomes like a must in all girls who are beyond 8 years of age coming with a complaint of the short stature. And if you find any suspicion of Turner syndrome, then it's become all the more important. Now, there are so there are multiple studies where the Dr. Deep has also made one famous one is the toddler Turner syndrome study, which even published its extension also last year, where they have shown the children who were started on an early age for the Turner syndrome on the growth hormone were much better as compared to the patients who were started on a very late age. Now there can be a debate regarding what age it should be. Can child should be started since the infancy if they diagnosed early as a Turner syndrome and short stature, or it can be somewhere around 3 to 4 or 5 to 6 years. So there is a no general consensus as such, but earlier they say, and the ideal age where most of the children will present with a short stature is around 5 to 6 years, and they say that you start around 5 to 6 years, then the advantage will be much more compared to if you start around 8 to 10 years of age. And even the latest toddler Turner syndrome studies extension also showed that the children who were started from the infancy onwards and the children who were even started at the late around 5 to 6 years of age onwards, both uh, ultimate adult height, the final adult height was almost similar. There was not much difference between the two. So probably we can start by 5 to 6 years of age. Regarding the benefit which we get is obviously it is one, if you start early, then we have to gain a more height as compared to the children who are started late. Second, if we have started early, then the puberty initiation can be also done at an appropriate age rather than we delayed the puberty initiation just for the advantage of gaining the height in the child.
So, Dr. Vineet, so as per your suggestion, like it has to be started 4 to 6 years, we have started at 4 to 6 years.
Yes.
Whatever doses you tell us, we have used in those doses.
Yes.
We have given sufficient period. So, what is the approximate estimate of improvement in the final height? So, what parents mean is what's improvement in final heights, and but in terms of centimeter, the total gain after use of growth hormone in Turner syndrome is what is likely from the Western series published where they have used early. So, what's your approximate estimate?
Okay. So, sir, usual dose which we start is with around 0.35 to 0.375 mg per kg per week. There are some data where they have even used it up to 1 mg per kg per week by monitoring the IGF-1 level. However, the recommended dose as of now is 0.35 to 0.375 mg per kg per week, with which we start. The usual duration is around 6 to 8 years of therapy. And when we counsel the parents, we tell them that we expect around 8 to 12 centimeters of the gain compared to the patients who were not given the growth hormone at the appropriate time. So the max gain we expect somewhere around 12 centimeter, and it varies between 8 to 12 centimeters.
So what's approximate duration where you can find approximately 7-8 centimeters of difference? So
six to 8 years of the growth hormone therapy. So we start around 6 years of age. The recommendation to stop is once the bone age reach around 14 years of age, or if the height velocity is less than 2 centimeter per year, then we need to stop the growth hormone therapy.
Okay. So you suggest that in Turner syndrome, we need not to do any stimulation test. If we confirm the diagnosis of Turner syndrome, the growth hormone therapy can be started straight away in the doses of 0.35
milligram per kg per
week, and is to be given subcutaneously daily injection, because right now we have a daily injection available in India. In future, we may have once a weekly, and started around the age of 6 to 8 years. We continue for 12 to 14 years. if we believe that puberty started at 12 years, so maybe up to 14 years, and final gain in final height is approximately 7-8 centimeters after using for that
Much
growth
bigger.
hormone. Although this may not be that much cost effective, but 8 centimeter means a lot for any girl who is short.
I completely
if
agree with that.
If available, it can be given. However, cost may vary, and we may find out some solutions to afford the cost of growth hormone. But 8 centimeter in any girl's life means a lot. So yes, we agree with your submission that it can be started as early as possible. Okay. So Dr. Atul.
Good evening, sir.
Yeah,
Good evening.
Dr. Atul. Yeah, good evening. So another condition is one is Turner syndrome, and most of the time when we do growth hormone stimulation tests are normal, but still child is very short, maybe less than 2 standard deviation, or maybe 3, or maybe 4 standard deviation. We did our best. We did all investigation. We didn't find any solution. So this is the term, new terminology has been used, is idiopathic short stature. So just to give us a brief account of what is idiopathic short stature, what does it mean, and who are the children who are likely to come in idiopathic short stature, and then elaborate on can growth hormone therapy can be used in the children, and what is our expected gain, what doses we have to use in idiopathic short stature. Starting with what is idiopathic short stature.
Yeah, so I think it's a very pertinent question. I think it is one of the most common reasons why the kids are being referred to us. I'll just share my screen. I have just few slides on this, if you allow me to do.
Yes, please go ahead.
Yeah. So I hope slides are visible.
Your slides are not yeah, now it's visible. Yeah, go ahead.
So, like you asked, idiopathic short stature is a relatively new condition. It is basically defined as if a person's height is more than 2 standard deviations below the corresponding mean height for given age, sex, and population group. And along with this, there should be no evidence of any systemic, endocrine, nutritional, or chromosomal abnormality. And also, the child should have a normal birth weight, and the child should be growth hormone sufficient. And if we look at the number of referrals, approximately 60 to 80% in some series have been shown to be a part of this subgroup, that is idiopathic short stature. And by definition, idiopathic short stature includes the children, those who have been labeled with CDGP, and those who have been labeled with familial short stature. So this is a group that composes of idiopathic short stature. So there have been different takes on whether growth hormone should be used, should not be used. And in 2003, FDA did approve use of growth hormone in idiopathic short stature. And this is one of the largest studies in which around 123 children were studied. And these were the children with idiopathic short stature, and they were given growth hormone in a dose of around 0.32 milligram per kilogram per week. And the authors did show that the children benefited to the tune of around 9.5 centimeters. And this was for the boys, and around 8.6 centimeters for females. And like you were telling us, for Turner syndrome, this is a big amount of height gain, and this does have an impact on psychosocial well-being of the children. So the mean age of the children in this study was around 12 years, and the mean duration was around 5 years for which these children were exposed to growth hormone. So there is evidence to suggest that if these patients are given growth hormone, these children do better in the later part of their life. And this was another study. This was a smaller study, and in this study also there was a significant improvement. You can see that as compared to the adult height, the control group, the adult height was much better in the treatment group as compared to the control group. So we have some guidelines also. The Pediatric Endocrine Society guidelines suggest that it should be a shared decision making. So we need to discuss this with the child's parents, and then it should be a shared decision.
because like we discussed earlier, that growth hormone is not a treatment that is absolutely free of harmful effects. So we have to, if we are planning to use this treatment, we need to discuss each and every thing with the child's parents. The treatment does affect height and psychosocial well-being of the patient, and this should be reassessed every 12 months. And we should use a restrained dosing strategy. So I'll be telling you what this means. The optimal age for initiating the treatment is 5 years or early puberty. There is no definitive data that we have currently that is available regarding the long-term safety of doses higher than 50 micrograms. FDA approves the dose that was told by Vineet also for Turner syndrome. It is 0.3 to 0.37 milligram per kilogram per week. Doing IGF-1 levels is helpful because it helps in assessing compliance. And if the levels are consistently above 2.5 SDS, then we should reduce the growth hormone dose in these patients.
Okay, Atul. So you suggest that growth hormone can be used in idiopathic short stature, but you have outlined that all systemic illness, endocrine illness, chromosomal disorder, systemic illness, first should be ruled out. Only if we rule out these conditions and
Then
we do growth hormone stimulation test, which is normal, and these are the conditions met, only then we can consider possibility of idiopathic short stature. And essentially it includes familial short stature as well as constitutional delay of growth and puberty. It depends upon bone age. If bone age is more delayed, more than 2 years delayed, they are likely to get greater improvement. But in case of familial short stature where bone age is not delayed, bone age is within 6 months, so in these children it's less likely to get a good amount of improvement. So one of the question I've just seen is regarding use in familial short stature. Results are not very great in use in familial short stature because their bone age and chronological age is same. If we use for start around 5 years, 6 years, and we continue for another 5-6 years, cost is phenomenal. And vis-a-vis, if you see the improvement in final height is 4-5 centimeters, 6 centimeters in case if bone age is not delayed, and if bone age is delayed, in that case improvement may be larger. Okay, so now we move on to Dr. Sachin. Hi, Dr. Sachin. You are muted.
Very good evening, sir.
Hi, good evening. So now important condition is one is Turner syndrome, we have discussed. Another is idiopathic short stature, we have discussed. Now nowadays we are getting many requests for writing growth hormone for those who are not having growth hormone deficiency and absolutely normal child. They are appropriate for their mid-parental height. Still, there is a lot of societal pressure that a child, if is taller, is better. So, what's your take on the point? Can we use in an absolutely normal child with intention to increase the final height? So, we use growth hormone in these conditions, whether growth hormone instrument test is required or not. And if we use in what doses we have to use and how long we have to use and what's the best time to start growth hormone, if you suggest that it can be used.
My experience in this field is very limited, sir, but usually I come across especially female child who have attained puberty and just attained menarche, and the parents are in a state of fixed because the child is not that tall as per their expectations, and somehow somewhere they want, Doc Sab, you should give something for the height. So that is where I usually give in such kind of cases who are basically not growth hormone deficient, but when we start growth hormone therapy in such kind of cases, actually the bone age, we have got a limited, as you were telling just few minutes back, there has to be, as per the chronological age, the bone age has to be at least behind, but how much it is behind, how much it is lagging, that actually counts a lot with respect to height. So such kind of children, they have this margin in a very less way. Most of the times it is around 13 and a half years. So the moment we start the therapy, and again the results are not very rewarding, as Vineet was telling us regarding the Turner cases, where we are giving in very high doses as compared to our routine doses of growth hormone therapy. So I will say, as per the literature, around 5 centimeters, not more than that. 5 centimeters, I am very optimistic if I'll say it is 5 centimeters. So most of the times it is not that rewarding, since the bone age is not giving us that advantage at this particular point of time. Earlier is always better, as we know. And regarding the doses, there is no clear guideline with respect to that. If I am giving such kind of patient, I'll be giving in the same doses like as per the 0.2 milligram per day, that is 0.2 milligram per day for the non-weight based therapy, or it is somewhere around about 0.004 per kg. Yeah.
Yeah.
So the usual
First
doses, as
point is,
mentioned.
first, it's absolutely normal child. Bone age is appropriate for chronological age, and height is absolutely appropriate for their mid-parental height. That means they have achieved their genetic potential till
Yes,
now.
sir. Mhm.
So in that case, would you suggest to use growth hormone or not?
Majorly, I will not give. But if
Yeah,
there
I
is a
fully
parental,
agree with you.
but if this
And
is a hypothetical question, where in situation we are seeing in metros, people are giving this. So I just went in for search for literature, but I could not get it. A very kind of a specific paper with respect to which is talking about this. This is very true. So in ethically speaking, I will say I will not give. But when you're giving it, it has to be if the bone age is less than 13, around 13 years. Most of the times, these children are the ones who must have crossed this bone age. So it's very difficult, and I will be giving in around if meant to. Till that, I have not given. My experience is with those girls only who have achieved menarche, and there is a parental and peer pressure. Otherwise,
yeah, we get such a type of request nowadays. It's become more and more frequent that child is short and you give growth hormone, they will have a better final height. So my experience and what is international literature about that is there is hardly any change in final height if we use growth hormone in a normal child. This is because if we give growth hormone, there will be sudden increase in the growth velocity for short period of time, but bone age also advances. So there is hardly any change in their final height if we use an absolutely normal child. Normal child means bone is appropriate for chronological age and height is appropriate for their genetic potential. So I have no experience. I have not used till now in any of these children, as also is international experience. So it may be possible initially they look taller, but final height there is hardly any change if we use in a normal child. So my suggestion is please refrain from using growth hormone.
True, very true,
Child
sir.
be normal.
Very true, sir.
So again, coming to Dr. Deep. So Dr. Deep, there are certain we have discussed Turner syndrome, idiopathic short stature, normal child, and as we have previously discussed that for the diagnosis of ISS, we should have all skeletal dysplasias to be ruled out. So now we are getting few referrals where child is having a skeletal dysplasia like achondroplasia or hypochondroplasia, child is short. So and parents request, even if they know that genetic potential is short, they would not be tall, but still they want that even if having child is having achondroplasia, can we use growth hormone in these children, even if to give 5-6 centimeters? Or is there any recommendations any society suggests that can be used in achondroplasia or hypochondroplasia, and what are disadvantages likely expected in these children?
Yes, sir. Very difficult condition. So like ISS, as we say, it's a basket disorder. When we are not able to put any diagnosis, we put them under ISS. Every month we are getting new and new mutations which are detected for ISS. Similarly, the dysplastic skeletal dysplasias are a huge basket of disorders. We have newer and newer mutations coming up. They may have short limb dwarfism, they have short trunk dwarfism, they may have a mesomelic or rhizomelic type of dysplasias. The problem in this is that their epiphyses are dysplastic, either focalized or generalized. And a dysplastic epiphysis will behave differently and less to growth hormone. So if we give growth hormone to these kids, first of all, their growth will be highly heterogeneous. It may further worsen the dysmorphism. So that's the important side effect we need to tell our patient, that the body disproportionate can further worsen. Again, the results are largely sketchy. Studies have shown variable outcomes. Most of studies have been done with higher doses than the doses which we typically use for treating growth hormone deficiencies. The longest studies which have been published is around 8 years follow-up data. And there they have noticed that the maximal improvement in best case scenario, we can improve the height standard deviation score by 1 or 1.15 standard deviation score only. Usually it is much less, only after 6 to 8 years of therapy, usually is only plus 0.5 standard deviation improvement in height. In absolute terms, if we talk, such kids, when they typically come to us, they have usually -5 or -6 standard deviation score, only marginally 4 to 5 centimeters height gain is there. So the outcomes are really guarded. Problems of worsening of body proportions is actually there, because the good epiphyses will respond slightly better. The dysplastic epiphyses will respond much less to the supraphysiologic growth hormone we are giving in these kids. So routinely we are not using, but in exceptional of cases where the patients are really motivated, after explaining all the possible complications, we may try in them, telling them that the outcomes are really guarded in them.
Yeah, I agree with that, Dr. Deep. Recently, Japanese Pediatric Endocrine Society has approved achondroplasia where growth hormone can be used. Also, although just to explain here that there is not great increase in height is expected. So after using 4 to 5 years of growth hormone in achondroplasia, what they could get is there is increase in the 4 to 5 centimeter in their final height in comparison to those children with achondroplasia who are not treated. And fully agree that yes, growth hormone is not like a molecule where there are no side effects. Growth hormone is also full of their side effects, and some of their side effects may be lifelong morbidity for that child. Another important side effect of growth hormone in these cases of achondroplasia is there is rise in intracranial pressure. And because there are abnormalities of foramina magnum has also been reported in children with achondroplasia, so there are more chances of herniation of brain. But these are not very well reported. And as you said, the literature with the use of growth hormone in achondroplasia is very sketchy. So only once it's discussed in detail with the parents about the use of growth hormone, we can think of using growth hormone. And before that, we need to explain them clearly. There will not be any great improvement, although there may be 4 or 5 centimeters improvement, which is in best scenario with their final height. But they will, even if there is 4 or 5 centimeter, their final height would remain quite short. So that's about achondroplasia, and similar results are there in other skeletal dysplasias also, although the literature is very less in comparison to the achondroplasia. But again, case to case basis can be discussed with the parents. Once we explain all these things and parents agree, we can think of using, but not a common condition. We need to tell them clearly that improvement is not going to be very great. So next is Dr. Vineet.
Yes, sir.
Yeah. So another condition which is commonly seen by endocrinologist also, and more commonly by the pediatrics practitioner, is Prader-Willi syndrome. So Prader-Willi syndrome, we know that have its own problems. So just elaborate on Prader-Willi syndrome. Can it be growth hormone be used in Prader-Willi syndrome, whether it's approved or not, and what are disadvantages where growth hormone therapy has been used, and what are our concern, and what is our target, whether improvement in final height or any other improvement. So can you just elaborate on that?
Okay. So Prader-Willi syndrome is one of the condition where we use the growth hormone not only for the growth per se, but even it can be used in the adult life also. I mean, based on the various features. We all know that Prader-Willi syndrome is a syndromic condition where it's mainly happened because of the genetic mutation, that's the deletion of paternal chromosome 15 mostly, or maternal parental disomy of the chromosome 15. So the common features which we all know that the initials it is with the early onset of severe obesity and hyperphagia with its own musculoskeletal deformities, I mean issues, dysmorphic features, multiple hormonal abnormality, cognitive behavior issues, and then obviously we see the growth hormone deficiency as well as they can even have the hypogonadism, sometimes premature adrenal, central hypothyroidism. All this can be seen in the Prader-Willi syndrome. Now, today's when we are discussing about the growth hormone therapy in the Prader-Willi syndrome, so it can be used. Now, there is a debate when it should be started or not. So there are some studies which have shown even when the child when the diagnosis was early and started during the infancy, they had the best outcome by the adulthood compared to the children with the Prader-Willi syndrome started later. Though there is a no consensus that at what age it should be started, but yes, looking at the certain advantage, we can say that the greater effects can be, I mean, it can be started as early as between 4 to 6 months of the age also. Though it's a debatable, but yes, it can be started as early as possible. So why it is debatable, that I'll come to that question also. The major advantage which we talk about in the Prader-Willi syndrome is something like there can, if we start very early, especially during the infancy phase, we can see lot of changes in the phenotypic appearance of the syndrome per se. That include obviously height, the facial expression, the head circumference actually is much more compared to the children who are without the growth hormone therapy, and then the acromicria is something that also improves. Then there is also improvement in the body composition with increase in the lean body mass and decrease in the percentage fat. Then they have also reported to have an increase in the muscular strength, and so there is an improvement in the motor milestones of the child with the growth hormone therapy. Then again there is an improvement in the cognitive level as well as, and then overall there is a positive action on the linear growth and normalization for the final adult height. Now the doses are something which is again kind of not yet fixed, but what they say that you start with a 0.5 milligram per meter square per day, that is around 0.25 milligram per kg per week, and then you need to kind of rapidly increase in within the first week to a month, that you reach up to somewhere around start with a 0.15 and reach up to 0.25 mg per kg per week. So in this again the same like a Turner syndrome, they have used a higher doses, but what they say is don't go beyond the +2 SD of the IGF. So you should monitor at least by a yearly IGF, and then you should not go beyond +2 SD of IGF. Now there are certain concerns which is very, very important for us to understand when we are starting the Prader-Willi syndrome, I mean growth hormone in a child with a Prader-Willi syndrome. The most important one is there can be sometimes sudden death during the infancy. There are reported deaths during the infancy post starting of the JS therapy. Now that could have been probably because of the increased so most of the cases were with the increased respiratory infection. However, there are also cases of sudden death due to obstructive sleep apnea, and then if there is a scoliosis, there may be worsening of this scoliosis also. So it is recommended in the consensus statement and the guidelines that a child who is already on a growth hormone therapy, they should have at least yearly polysomnography to look for the obstructive sleep apnea and yearly ENT examination, especially to look at the adenoids and the tonsil, because sometimes this tonsillar growth and the adenoid growth can lead to the obstruction and recurrent infection. So they sometimes they even suggest that if it is too much, then we can even plan for the surgery once we put the patient on the growth hormone therapy. However, during the transition phase, it is said that it is better to go for a growth hormone stimulation phase. What I mean by the transition phase is from the child to the adulthood. When we are thinking of the growth hormone therapy in adulthood, we need to do the stimulation test. If we find it is definitely less, then we can go ahead with the growth hormone therapy during adulthood also. Some papers recommend that we don't have to do that. We can continue with the growth hormone therapy, but considering the cost and the feasibility, we need to kind of individualize that case.
Yes, yes. agree with your views that yes, growth hormone can be used in Prader-Willi syndrome if it's correctly diagnosed, but use is not that simple. We have to do a lot of tests, and we have to rule out first that if there is any sleep apnea or not, and if even if during treatment sleep apnea appears, we may not like to continue growth hormone these therapy, because sudden infant death and sudden childhood death syndromes have been reported in these cases with Prader-Willi syndrome. So it's not a simple decision. So my suggestion would be, so even if a case is coming to a pediatric practitioner or general physician, since it's a lot of issues have been related to the growth hormone therapy, so it's always better to refer that child to nearest endocrinologist who can think of starting weighing of the pros and cons and explaining to the parents. It's not simple to start in Prader-Willi syndrome, and only after discussion with family, explaining all these issues, and then investigatively, only then we can go ahead with growth hormone therapy, and yearly their follow-up and investigations are required to continue growth hormone therapy, not only in terms of height, but as you have said correctly, there are a lot of other improvements, increase in the muscle mass, which has been seen in these cases. Okay, so another condition which is not quite common, but at times we do see. So, Dr. Atul.
Yes, sir. Yeah.
Yeah, Dr. Atul, another condition is, as Dr. Deep has said initially, is chronic renal failure before transplantation. Although these children are having their primary illness, which is resulting in chronic renal failure. So, how much we are justified if we use growth hormone therapy in these cases of the chronic renal failure, and how long we can use, and can it be used post transplantation also in an attempt to improve their final height?
Yes, sir. So, both in a CKD patient is restricted because of multiple reasons. Anemia being one of those, metabolic bone disease, recurrent infections, but there are some specific issues related to growth hormone excess as well. It is a growth hormone state because of reduced levels of IGF-1. There is an upregulation known as SOX protein, which is a reason for growth abnormality in these kids. So there is some evidence regarding use of growth hormone in CKD. So study done in around 38 patients, and these were the kids who were treated for around 5.5 years with the growth hormone. Their bone age at the start of the study was around 7 years. And this is what happened with the patient who received growth hormone. You can clearly see that both boys and girls who received growth hormone had a better height outcome as compared to both. We have evidence to suggest that exogenous growth hormone definitely works in patients. And these are the latest recommendations for use of growth hormone in patients with CKD. So any children with the stage 3 to 5 of CKD or who is on dialysis for past 6 months should be a candidate for growth hormone if they have a persistent growth phase, which we already defined. So another question that you asked, Dr. Deep, was whether it can be used in a patient who has received kidney transplant. Yes, this treatment can be used, but we have to make sure that it should start 1 year after the transplantation. Even if after transplant the child has not achieved the catch-up growth, then these are the patients who are candidates.